So with this kind of a thing, diagnostic labs are definitely a bridge between the technology and healthcare, and it is very imperative to keep pace with the entire thing. So this is again like genetic disorders could be caused due to single gene. It could be multifactorial. It could be chromosomal or mitochondrial. So basically, the study of structure, and function of genes at the molecular level is genetics. So when I come to genome and genomics, we have about 20,000 to 25,000 genes in our body, of which 5,000 are the disease-causing genes. So basically, this happens to be the 200th anniversary of Gregor Mendel, who has actually laid down the foundation of genomic sciences. So basically, amongst the 5,000 gene, again, 85% of the genes lie in the exomes of the gene. I'll just come to it in the slide later. However, like when we are looking at the complex genes, there are a lot of genes that we need to check at one point of time. Let's say with autism or global developmental delay, these kind of things require. Even now, recurrent pregnancy loss has, we've seen that there are a couple of genes which are quite, related to these kind of conditions. So again, about genome. So, genomics, like we are talking about next generation sequencing as of today. I'll cover some of the very basic molecular techniques for every lab to get into it. But this is now slowly moving from illness to wellness. That means we know that these are high-end testing, they cost a lot. So not every patient can afford this kind of an exome testing. But sometimes we also come across people now coming for carrier testing, pre-marital or during, post-marital stage also. They just come down to check whether I am a carrier of certain disorders. And if I am a carrier, is my spouse is also a carrier in case of autosomal recessive disorders. So slowly the trend is moving from illness to wellness. But yes, in our developing country, it is still going to take another 5 to 10 years wherein, people would actually want to come and check that, do I have some, very pathogenic genetic variants and do I have to worry about it? But this is how the genome, we look at the whole situation. Molecular pathology. So the molecular techniques for any lab, like, to offer a simple testing, just for looking at a single gene disorder, there are like a lot of these areas which can be covered besides the reproductive genetics. So we are talking about the pharmacogenomics. So we have genetic, we have single gene disorders where we look at beta thalassemia, spinal muscular atrophy, DMD. So there may be a family who's already has an index child with one of these disorder. So how can we offer prenatal diagnosis to such couple? Do the parents really need to be tested for an autosomal or disorder? Y chromosome microdeletion in terms of infertility in an IVF center, the kind of preliminary testing that is offered to the couple also includes Y chromosome microdeletion in the male. And then there are ataxias and, its significance in hematology. So let's say thrombophilia, when we look at RPL, although there are quite discrepancies whether, really the thrombophilic panels or the genes that are associated with thrombophilia, is that really a cause of recurrent pregnancy loss in the woman? So, but these kind of markers are available to assess the feasibility of the same. And in reproductive genetics, of course, we have NIPT and prenatal diagnosis. So NIPT is which something everybody knows about, but how important it is and should we really actually have that replace the dual or quadruple markers. And then, of course, prenatal diagnosis. So if we have a disorder in a family, how best we can offer the woman prenatal diagnosis. So basically, it is for detection, predisposition, a prognostic predictive value, recurrence monitoring, and drug selection, besides the prenatal testing. Coming to the different molecular tools that every molecular lab has or a diagnostic lab has, I'll just come down to it. But this is a little about gene aberration. So whenever we report something, a genetic variant, we call it either nucleotide substitution, or it could be an insertion, or it could be a deletion. So if we actually look at substitution, the one CGT has changed into CCT. So something like that, even a small nucleotide change in the gene is called a point mutation, and those point mutation could be causative of the disorder. Insertion is like when there are 1 or 2 nucleotides which are added on, and deletion is something where 1 or 2 nucleotides are deleted out. So basically at the genetic level, we have these terminologies. In the chromosomal level, like there could be inversion of the chromosomes, or a translocation, or a duplication of the chromosome. So these are the very common terminologies one would, see in a genetic report. Coming to this this is an important slide wherein, like, we what we need to tell you is that, PCR is polymerase chain reaction, where we actually look for this kind of a change. When I said C to T, we do a PCR of the genomic DNA, and then we apply the primers or probes and come down whether there is a mutation or no in this family. So PCR is a targeted mutation testing, which is like as simple as, and it's a very low cost kind of a test once we know that the couple is suffering from a particular disorder. Coming to Sanger sequencing, that is when we are not only looking at the particular regions. Let's say for beta thalassemia, like we know that it is very prevalent in the Gujarat population also. We see it in Kutch Lohanas and all, to an extent of 12% as much. So but in that, what happens is that we know that there are 5 common mutations which are the cause of thalassemia. But suppose if I did not know the ethnicity, I may want to screen the entire gene, and that's where Sanger sequencing comes into play. Just mentioning this because whenever we come across any genetic report, the methodologies would be something like this. Then coming to microarray, which is the most important test as of today in terms of reproductive genetics, especially in products of conception. So, karyotyping, cytogenetic techniques like karyotyping of fish, which looks at the chromosomal structure variants, or, copy number variants. We also have microarray because product of conception is a very difficult sample to handle. And it needs viable cells, so although karyotyping happens to be a gold standard, but microarray is now the choice because however degraded the sample is, it's easy to get the DNA out of that sample and do a testing on the DNA for the same thing that we would look into karyotyping. Of course, there is a very minimal, difference between the two. But for products of conception, microarray happens to be because we look at the gene expression profile for the same. NGS, which is next generation sequencing. Now, this is, as I said, that if we are looking at, let's say, autism, and there are multiple genes that I want to do. So, you are going to ask the patient to, screen for gene number 1. Okay, I didn't get an answer. Now come to gene number 2. And that's how the sequential cost for each test will increase. So not to subject the patient to too many things, a panel of, let's say, autism can be run together. So those 7-8 genes can be sequenced at one point of time. And that's why it becomes cost effective, and you can get the variants, if any, in that patient. Again, MLPA is some technique where we only look for deletions and duplications in the gene. So let's say if there is like Duchenne muscular dystrophy or spinal muscular atrophy. So instead of, going to the variations, and we know that these disorders are only caused by deletion duplication and nothing else. So in that point of time, you do an MLPA, which will just tell you, whether there is a deletion or duplication. So if we look at the picture out here in this side, there's a threshold over here, the middle one. There's a threshold, and something above the threshold is a duplication. Something below the threshold would be a deletion. So for something like this, if I know that there's a patient with Duchenne muscular dystrophy, why would I want them to go for an NGS test, which is expensive and which is actually not needed? You can do it with a simple technique. So which is why the topic of the presentation is also that which genetic test and when. These kind of tests to them. Fragment analysis, when we look at repeat expansion, and let's say there is a Fragile X syndrome and the mother it's an X-linked disorder, the mother has to be a carrier of that disorder, right? So in that case, just to a simple fragment analysis test will suffice, and it gives me an answer in, let's say, 4 or 5,000 rupees, as against a 25,000 testing for NGS. So this is where we need to look at the entire thing and do it. So that's how it says that one size does not fit all. These are the different, equipments that are being used in every lab for the testing. There could be a simple PCR, there could be a Sanger sequencing over here, and these are the, like the Iron Gene Studio, which is the NGS platform on which we perform our NIPT testing over here. So if we look at the, the feasibility of every technique that goes through, so we see that the PCR based methodologies have a limitation up to, 10⁻3. When we go to MLPA, Southern blotting, and all these technologies, there's something of NGS which, covers most of the entire, panel that every other technique would have done as a limitation. But yes, again, it's an expensive test, and in our country, we are still far away to directly prescribe a NGS testing, which can make life easier rather than doing a sequential test. Reproductive genetics, here I would just take some examples of single gene disorders, microarray, and PGD testing. So here, if we see, like, if I'm talking about beta thalassemia, then that's how, the aberration, it's an autosomal recessive. So both the parents have to be carriers of the disorder. So here in our Indian population, we see that about 85 to 90% of thalassemia carriers have, a mutation in the 5 common mutation panel. Only very rarer ones need to, and ethnically it's different. So let's say if I'm looking for a Sindhi population, I know that besides the 5, I'll have the 6th one, which is the most common in them. And having worked in population genetics for so long, we know the spectrum of mutations in every community per se. So it gets easier. Rather than doing a high end, you can just look for the 5 common mutations over here. So in such a case, we just do a HPLC, which is a simple screening test, which will tell you whether you're a thalassemia carrier or no. So instead of then asking the woman, in her normal antenatal care, if she is found to be a carrier, instead of doing a DNA testing first, let's do the spouse. If the spouse doesn't have a carrier status, then she's not at risk for having a beta thal major child, an affected child. So it starts with the HPLC of the spouse. If both of them are carriers, only then we do a mutation screening. And if, like when the mutations are identified, then in the fetus, by doing a chorionic villus or amniocentesis, we can look for the same, mutations in the fetus. So these are the 5 common mutations that I was talking about. Besides that, we have, like sickle cell, HBE and HBD, which are like the common hemoglobin disorders that we come across. So it depends again ethnically. In some of the tribal populations, you can see sickle cell hemoglobin right in the Gujarat population also. Whereas HBE and HBD are for the east and the northern population. So normally we suggest, amniocentesis or fetal blood. Of course, fetal blood now nobody does it, but if the lady has, presented quite late and if amniocentesis is not good enough, then probably a fetal blood is there. So parental mutations to be identified and then tested in the fetus. Coming to Duchenne muscular dystrophy, again, this is an X-linked disorder. That means mother has to be a carrier of this disorder, and she may have 50% of her male children affected and 50% of them would be normal. So in such children, they are like apparently normal in the first 1 or 2 years of life, and later on, due to the aberration in the dystrophin gene, these children find it difficult to walk, sit, climb, and then they are like almost subjected to the wheelchair. So for such a kind of a thing, with all the other clinical presentation and elevated CPK levels, a deletion duplication test just to look for the exons, where there is a genetic variant over there, becomes important. And once we know that, we look at the carrier status of the mother, because many a times we have noticed in the genetic testing that many a times if the child has Duchenne muscular dystrophy but the mother is not a carrier, so when that happens, we call this a one-time event or a somatic event, that it has happened in the in the cells of the child during birth, but it's not passed on from the mother to the child. So that's where genetics becomes a little more complex. And although I know that, okay, this child is Duchenne muscular, I can just simply ask the mother to test, for a prenatal diagnosis. But what if she's not a carrier? Then why do I even ask her to do that? We are subjecting her to that 0.5 to 1% fetal loss during amniocentesis. So that's where it is imperative that once I've seen in the index child, then quickly go back to the parents, or in case of X-linked disorder, we look at the mother status, and then we recommend the kind of test to them. Similarly, spinal muscular atrophy, again, these are like, both Duchenne and spinal muscular, both are like genetic disorders where there is a very small change. You can just go to the genetic level or do an MLP and quickly get an answer over there. So that's where we look at the child. Again, here, this is an autosomal recessive. So both the parents have to be carriers for SMA. So again, we check that whether, that aberration is present in both the parents, and then suggest, prenatal diagnosis for some of this. Y chromosome microdeletion, as I said, we look at the AZF region of the Y chromosomes. We do a 16 exon deletion test, and from there, if we look at the gel pictures over there, the missing bands that we see over there indicates deletion in the Y chromosome. So these are the very simple single gene disorders that I was talking about. Coming to chromosomal disorders, we know that although karyotyping and FISH are gold standards, but there is some molecular method called QF-PCR, which you can look at the same chromosome, the common chromosomal aneuploidies, by doing it on a DNA testing. It's a little rapid test and you get the results even sometimes within 24 hours. So sometimes if the lady is at her 20th, nearing 20th week of pregnancy and she wants to do a quick test, she may have done a karyotyping also. But if she wants to do a quick test and she knows that, okay, now she's trisomy 21, and depending on the other clinical or the ultrasound findings, the soft markers, one could even probably take a decision on that. That's because when she is reaching 20 weeks, suppose the lady was at 15 or 16 weeks, she might as well wait for the karyotype results to come out so that she can take a clinical decision based on this. But QFPCR is something for very advanced gestation and all. Now that we know that 24 weeks is the cutoff, however, most of the times, I think 99% of the time, we consider 20 weeks as much. So that's how a rapid test would be most welcome in such a scenario. So when I'm talking about the chromosomal disorders, the commonest ones are chromosome 21, 18, 13, and sex chromosomes. In sex chromosome, there is Turner syndrome, there could be a Klinefelter syndrome XXY, and triple X and triploidy. And the other triplet repeat disorders, I'll just skip this slide, but sometimes we see Fragile X as a common, disorder where we need to look for where we need to offer them prenatal diagnosis. So these are the kind of repeats of what I was talking about, the fragment analysis. There are repeats. So when I say CGG, there are CGG repeats all over your genome, I mean, on that region of the X chromosome. So anywhere like between 5 to, let's say, 35 repeats are common in you and me as well. But somebody who goes beyond 35 to 200, that's where there is an indication or a red flag that, okay, well, this patient could be a carrier of Fragile X syndrome. So that's how it helps the lady, once we have these kind of things well ahead of time. I'll skip the pharmacogenomics. But for thrombophilia, we have factor 5, factor 2, MTHFR variants, which are like usually as a package. If somebody had to go for a bad obstetric profile package, that's where along with the karyotyping and the other tests, like they do recommend the thrombophilia markers also. Coming to reproductive genetics, these are the various challenges that a lady faces right from menarche to menopause, and these are something where genetic disorder testing, although a small proportion, can help her sort the issues. So what has changed in the last decade? That quite a few things have moved from invasive to non-invasive. Sir has already covered the NIPT bit in the first half of the morning, but I'll just quickly go through because this is a part of one of the genetic testing. So the invasive, of course, it is the gold standard. It is a diagnostic test, but it also comes along with a 0.5 to 1% risk of fetal loss. There are papers which even talk about 2 to 3% as well. But even considering the lower cut, a lot of women are little reluctant to go for amniocentesis unless really needed. So, and what has moved from there is the non-invasive testing. The ultrasound is already there. So serum screening, marker screening, the dual and quadruple markers, and NIPT over here. So, so in the non-invasive bit, the NIPT, although is one would say that it is one of the best screening methods, but I would call it a best screening method for Down syndrome, for trisomy 21, because it comes with a higher accuracy for Down syndrome. With the kind of data that we have in our own lab, we see that, when I did an end-to-end correlation, I do see that trisomy 18 and 13 also have been concordant results when they did an amniocentesis. But however, with 18 and 13, very rarely they need to go ahead for amniocentesis. Probably the markers itself would, suggest the same. But when we chased the trisomy 21s, we saw that, my NIPT result, the dual marker was high risk for trisomy 21, NIPT was high risk for 21, and all these high risk 21s, when they were confirmed with amniocentesis, they were all, they showed all concordant results. The very low ones are the sex chromosomes, because there we see a lower accuracy. So sometimes due to placental mosaicism, the mother may have, mosaic cells. One would be, XO Turners and a normal X. And that could have actually, impacted the results of the NIPT. So normally who should be doing the test? Of course, with the ones who have high high marker testing results, or if they have had previous, affected pregnancies, or if and these days we see a lot of the advanced maternal age. So they may not have had a, high risk on dual or quadruple, but because of her age, the NIPT is usually asked for. This is usually a test not suitable for women with medical conditions because these, there are some chromosomal, as I just mentioned, placental mosaicism can really impact the results. And if she has been under some therapy, those also could, like the tumor cells for that matter, are very prone to have chromosomal imbalances. The test can be
Excuse me,
performed.
ma'am. So I'm sorry to interrupt you. Time, we are running very short of time, and the time is over already. So please finish as soon as possible.
Sure. Sure. So this is just a workflow NIPT. I'll skip this one. This is one NIPT data that with the 50,000 women that we screened, and from 2,000 of them were like a high risk. Only 66%, 66 women was shown to be high risk over here. That means 97% of the women actually did not need amniocentesis. So before NIPT came through, all the high risks were put across to the for invasive testing, but because of the NIPT, there has been a larger filter and it doesn't require anything. The microarray, as I just mentioned, microarray, the only difference, I have just last one or two more slides to wind up with. So the microdeletions and duplications, the karyotyping and fish testing, but microarray important for POC samples. Fine. I could stop over here. This was just the implications of all the genetic testing that could come across. I had some genetic counseling, which is important because genetic counseling, at the end of the day, the doctors do their best to give the entire counseling to the patient, but sometimes the patient needs to be taken through the basics of what is chromosome, what are translocations. These are very difficult terminologies for the women. So we also offer genetic counseling to them so that they can take a decision whether they should want to do it or not. Thank you for your patience.
Thanks a lot, ma'am, for giving us such a detailed knowledge on this topic. This topic is a topic which usually we gynecologists run away from. And now I request Dr. Samina ma'am and Dr. Anup sir to facilitate, ma'am. Next, I request Dr. Mayank sir to come up for the next session. He'll be guiding us on basic and extended fetal heart survey.
दिल का रास्ता पेट से निकलता है. We have finished our pet and now we are going towards the dil. People only see what they are prepared to see. In fetal echo, you have to be very much understand the pattern. Most difficult thing in fetal echo is at the end of scan when you tell that this baby is normal. Declaring normal is the most difficult thing. Regards from Mayflower Hospital and my team. And
a very forward to chair the session.
So I will drop the link for this Sonok Academy, which is good knowledge sharing platform where you will able to learn, you will able to share your view, and it sharp start every Wednesday at 9 a.m. and stop at 10 a.m. and it is a wonderful platform. I will share a link in a common group. You have to log in one day ahead, and once you are logging, then the thing will become simple. Just before 5 minutes of 8:45 a.m. you will open it and press on calendar and that particular date, and you will able to join. And this all session are moderated by Mediscan, and you know what is the Mediscan flavor. You will be constant touch with that. So please be please log in, and it is very simple. And today morning sir was telling regarding emotion of the baby also can be seen, and we are seeing the emotion. And when one mother share with other mother that I have seen my baby like this, or when the sonography company come with various images like this, at that time the expectation of patient is very high, and the reality is different. Okay, so in my talk, this is my disclaimer, that if you have come with the expectation that after end of this talk you will able to diagnose all 1.5 millimeter VSD, 2 millimeter VSD, 1 millimeter VSD, ASD, mild coarctation of aorta and bicuspid aortic valve, no, you will be disappointed. And again, that is not a goal of screening fetal echo. We have to do reverse engineering. When you suspect it, go and see heart as per screening protocol, and once that is normal, you can ignore this finding, or you can review this finding. And when you think that after this talk I will show some demo in machine and you will learn like easily, but things are not like that. So what is my hint to you for a fetal echo after this talk from Monday morning? You start looking fetal heart around 22, 23, 24 weeks when the spine is posterior. Okay, and try to apply what I showed to you, and gradually come down to 18 weeks, then to the first trimester. So here the images are very selected one to impress you, but please don't get impressed by that. I have selected for your understanding, not to impress you. The maximum information which we can get in heart is a apical 4-chamber view and lateral 4-chamber view, and basal 4-chamber view will give very less information. So whenever there is a lateral 4-chamber view, you have to manipulate a probe slightly and make it to apical or a semi-apical. And there are various guidelines, and please remember that is guideline is not a legal document, but guideline is that minimum you have to achieve, and after achieving that you have to push yourself further to achieve more and more thing. So in 2006 there was ISO guideline and examination of fetal heart, and you will be surprised, this is 2023. In their guideline they told that in basic cardiac examination there was 4-chamber view only, situs and axis. 3-vessel view and outflow track view was considered as an extended fetal echo or expert fetal echo, and RVOT and LVOT examination was done as per added protocol, and there was no inclusion of a 3-vessel trachea view or a color Doppler at that point of time. Then comes 2013, and they include 3-vessel view and 3-vessel trachea view, RVOT and LVOT with a different protocol what we see nowadays, and they recommend the color Doppler and 3D 4D, but it was not included in a guideline. This is 2013, way back. And on this Wednesday morning I got this guideline, 2023 guideline. So this is oven fresh guideline, garam garam cha khawani maja avse. So here they included color Doppler also, and they included first trimester, early echo and color Doppler in a first trimester, and still the 3D 4D they recommend, it is not included in a guideline. First trimester already taken by Dr. Swati and Dr. In demo and talk, so I will not go in detail, but I will tell you one thing, it is early fetal echo does not mean that if you do fetal echo at 10 a.m. So early fetal echo when it is less than 16 weeks or in a first trimester, that is a early fetal echo. What we have to see, beating heart regularly, beating heart regularly inside thorax. You have done fantastic job. Okay, then if you want to push yourself, then you have to document that heart and stomach is on same side, extraordinary thing. Okay, and then if the CRL is more than 65, then go for inflow and outflow track and situs. So that's all. I'm going to skip this first trimester in today's talk. And thanks to this revolutionary landmark paper in 1999 by Yu, and he suggested the idea of this 3-vessel view for the diagnosis of outflow tract anomaly and cardiac anomaly. And it was slightly modified by Simchai Ajal in 2002, and now we are more and more doing this 3-vessel trachea view. And learning curve for 3-vessel view is very easy, and interpretation is mathematical. So to time constraint, I will not go into detail, but learning curve for 3-vessel view is very, very simple. In twins, in awkward position, in spine anterior, whatever it is, you will able to achieve that. And once you have a habit, then you will able to interpret that very easily. This is a paper in 2008, analysis of nearly 8,000 patients. And when 4-chamber additional LVOT, additional RVOT, and this 3-vessel trachea view was involved, the sensitivity of cardiac anomaly diagnosis jumped from 65 to 81%. And the negative predictive value was very high. It is 99.9%. So at the end of scan, you will able to tell this heart is apparently normal. Okay, at the end of scan, that is a fantastic thing. Okay, why there is a need of screening? Because the cardiac anomaly, the leading cause of infant mortality and morbidity. Prenatal diagnosis definitely improve outcome prior to intervention. That we will learn in next talk. And prenatal awareness regarding cardiac disease, and after counseling parent allow them to prepare mentally and emotionally, along with deciding location of birth and place. So detection rate is quite dependent on expertise, learning curve, maternal obesity, transducer frequency, you should go in a higher frequency, abdominal scare, gestational age, amniotic fluid. More the fluid, baby is moving constantly. Less the fluid, baby occupy one fixed position. So these are the hurdle, and you should have a very low threshold for echocardiography referral, and you should have a convenient access to fetal heart specialist. If you have more access, then you will able to diagnose more and more. So this is basic prerequisite. Mid trimester 11 to 18 to 22 weeks period. Optimal frequency, you will use harmonics, you will zoom the image after survey. At least that should fill half or 1/3 of the screen, and you will use GYNELOOP generously for the examination of opening and closing of atrioventricular valve. The basic grayscale setting, zoom, 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 zoom barabar zoom. So in fetal medicine, in first trimester, everywhere the zoom barabar zoom. Sector should be narrow. If we keep sector narrow, the frame rate will jump, and for cardiac examination, frame rate more than 40 is recommended. And now there is a auto, but if your machine is not auto, you have to select a single focal zone at the level of a heart, and you use various tools like SRI, CRI, and harmonics. To add the color in life, the color Doppler, we have to increase the PRF high to mid, again wall motion filter also, because Doppler can detect any moving thing. The heart is also moving, so there will be artifact. So wall motion filter should be high mid, and angle of insonation should be as between 0 to 20, and you have to think in a direction of a flow. And whenever you are in doubt, you have to set a duplex image, left side grayscale, right side a color, and selected case M mode can be used. So in survey, we will sweep from abdomen to neck. There are 5 sections to be taken, and first this is sweep from abdomen to neck. The abdomen, the same section which we AC section is used, then there is no magical movement. So fetal echo is not magical. 90% baby are in cooperative neutral position. From good AC view, you will slide your probe and go to 4-chamber and then to the neck. So that is one shortcut to go to 4-chamber view. Another shortcut in neutral position, when you are able to see easily fetal lips, when you tilt the probe, you will get fantastic 4-chamber view. And once you did this survey, then stay at 4-chamber for some time, stay at outflow track for some time. Cardiac axis, how to take, morning we have seen, we will draw imaginary line in interventricular septum, and again from midline to spine, and it should be 45 plus or minus 20. If it is left side, means axis is more than 65, then there is chance of cardiac anomaly, outflow tract anomaly particularly. If it is right side deviation, then there is a chance of space occupying lesion like left side CDH and left side CCAM and all those group of disorder. Here there is a small hint that when you draw a line, this descending aorta should be on slightly left side. If you are intersecting this descending aorta, that can be hint for a right side aortic arch, or if this descending aorta is completely on right side, also it can be hint for a right side aortic arch. Situs, you can see here, you have to label spine, stomach, portal vein, clockwise direction, and the heart should be on the same side where the stomach is seen. And we will consider this situs solitus. Situs solitus word does not mean heart position. That word means the abdominal viscera position and atrial morphology. But we cannot see atrial morphology. So for the surrogate marker, we are seeing the visceral organ. And there are various ways to define situs, the thumb method and various method. The best method is when you imagine yourself inside the uterus. That is the best method for defining the situs. Okay. When baby is in cephalic and breech position, things are simple. You can do like this. If it is clockwise, cephalic, anti-clockwise, breech, and immediately you have to confirm. Not after 5 minutes, because in 5 minutes baby can change position. So immediately you have to confirm it is in position like that, or you can document situs as Dr. Swati showed in the morning, that 4 image like that. But when there is a twins, when there is a oblique, in that case this may fail. Okay, when baby is in awkward position, this may fail. In that case, you have to imagine yourself inside the uterus, and you have to imagine that which will be left organ, which will be right organ, and it should be like that. If it is transverse, head is towards you, you will consider that as a cephalic position. If it is transverse and head is away from you on the left side maternal pelvis, then you will consider that position as a bridge position, and this orientation will be like that. So survey of a fetal echo in the same way, survey of a 4-chamber view, you will remember acronym PASS, PASS. You have decided the position of heart is on the middle and slightly left side. You have decided axis is 45 plus or minus 20. You have decided situs that stomach is on left side and heart is also on left side, situs solitus levocardia. And after that you will see the heart is squeezing properly or not, and this you will see the symmetry of ventricle and atrium. So this is a primary survey in a 4-chamber, but then you have to go for a detailed examination. So list is big. There is a 20-point examination of a 4-chamber view. I will give very briefly. This is a 4-chamber, and additional information what you have to see, that the cardiac rhythm should be regular and there should not be any pericardial effusion more than 2 millimeter. Up to 2 millimeter it can be artifact, or it can consider as a physiological. If you are struggling too much for the examination of heart and your angle is awkward, in that case this artifact of pericardial effusion is created, but always it will be around 2 millimeter, not more than that. In atrial chamber, you will see, you will label the left atrium by the insertion of pulmonary vein or opening of foramen oval flap. To look that is difficult in thin line patient, you will able to look that, but pulmonary vein examination is mandatory, and primum septum should be seen and crux should be seen. So at least one pulmonary vein entering left atrium should be documented. In ventricle, it should be approximately equal size, no ventricular wall hypertrophy, and in right side ventricle will look slightly dirty or like slightly small due to the moderator bend. And you can see this is apical 4-chamber view, and I 1 2 3 4 VSD like thing are seen, but don't afraid this, that is a echo dropout. And as I told you in my disclaimer, I'm not going to teach you diagnose 1.5 millimeter VSD. Don't broke your eyes. AV junction and valve, you have to see that this apical insertion of tricuspid valve, or we can say that offsetting of atrioventricular valve, simultaneous opening and closing. You can use a cine clip like this. You can see here there is a slight offsetting, and this is opening simultaneously and closing also simultaneously. So you have to use cine loop. This is very simple. So first section is abdominal section which we take a ACA, and you can see here this stomach, descending aorta, and IVC should be on the opposite side of stomach. Once we label the situs, then we are not worried regarding left or right. Okay, so the stomach on left side, IVC on another side, and if we draw an imaginary line, then you can see on left side there is stomach, on right side there is IVC, and this IVC size should be smaller than descending aorta or equal. That is okay. But if it is bigger than descending aorta, this IVC size is bigger this aorta, then it is a hint for some cardiac anomaly or abnormal ductus connection or position abnormal. Means this IVC, if it is near the descending aorta, then that is a hint for a heterotaxy. But if you are slight, just a 5 millimeter lower down in abdomen, this will be in normal situation, it will look like that. So you have to remember, stomach should be seen in this section and liver also should be seen in this section, otherwise artifact will be created. And this is a 4-chamber already I have described. This is insertion of a pulmonary vein, and this is offsetting of valve, and this is a moderator band, smaller or dirty looking right ventricle and a clean looking left ventricle. And adding, now the color is added, adding color in life. In 4-chamber you have to put a color and you have to play with the button. One button is a color gain button, another button is a acoustic output button, and third button is a PRF. You have to play with that button, and then you have to create a laminar flow. Okay, and the velocity PRF should be around 60 centimeter, and there should not be major regurgitation. If it is there, then there will be a aliasing artifact will be seen at the level of atrioventricular valve. Then the first thing coming from 4-chamber towards the neck, first thing you will able to see the alveoli, and then you will able to see the pulmonary artery. Pulmonary artery is the most anterior vessel, and due to shadowing of this pulmonary artery, sometimes this artifact of VSD is also created inside this aortoseptal area. You will put a color Doppler, and the shape is boot shape, or we can tell this shape of alveoli is a sigmoid shape. And if it is RVOT, it will immediately bifurcate. If it is LVOT, it will not bifurcate. This is how you will able to differentiate LVOT and RVOT. Then if you come 1 or 2 frame higher, then you will able to see the RVOT and circle sausage view. You can see the right branch of pulmonary artery and the left branch of pulmonary artery. Sometimes, many times, you are able to see the ductus arteriosus. To get the left and right both branch is slightly difficult, and it is not recommended that you do each and every time. But to see the ductus DA and the right branch, that is mandatory, that you have to document. Why you have to document? Here you can have a reference, nearby reference. When you are suspecting a small aorta, here you can see this normal situation. The size of MP and size of aorta is almost same, or aorta is slightly 1 or 2 millimeter slightly smaller in normal situation. And if there is a coarctation of aorta, the size will be as same as right branch of pulmonary artery. So it is nearby reference. Okay, when you start suspecting it, or always it will be smaller than SVC. So here there are 2 reference. Ideally, you have to go and see the G score, and please remember, G means Z score. At the end of ABCD, it comes last. That means it is not a difficult thing; it is a simple thing, and making a life simple. So don't think that છેલ્લે છે એટલે આપણે હવે ત્યાં સુધી તો ક્યારે પહોંચીશું ABCD થી, એવું નહીં રાખવાનું. You have to use it, and this is a right and left branch of pulmonary artery, and here somewhere there should be descending ductus arteriosus, which is not seen. It is okay. And if you manipulate your probe slightly, then you will able to see this ductus arteriosus and this right branch of pulmonary artery. Okay, if you are not able to see left branch, it is okay, it is not a mandatory. Then if you go 1 or 2 frame higher, you will able to see the transverse aortic arch, and you will able to locate a trachea. Location of trachea is quite important. You can see here, this is a MPA, this is a aorta, and this is a trachea, and this is a SVC, and this is creating a somewhat V-shaped. So 3 vessel trachea view, or many people are telling 3VT view, and this aorta is on the left side of a trachea, so it is called a left aortic arch, that is a normal. And when this aortic arch is on this side, it will create a U-shaped, and that is called a right aortic arch. And if this ductus is on the right side of a trachea, that is called a right ductus. Normally ductus is on the left side. So that is a very tricky anomaly, because the 3VT view shape will be maintained when it is that situation. But as a isolated, again, you can go ahead with the pregnancy. It has a less clinical significance. And when you put a color Doppler and apical 4-chamber view, in inflow it will be red, outflow it will be blue. This is a P arm, this is a arm, this is trachea, and this is SVC. And velocity here is high PRF, so SVC flow is low, so we are not able to see. But if we do slightly low PRF, then you will able to see the red signal. So please remember, these 2 color should be always same. When there is a reversal of color, almost always it is a anomaly, and you have to try what is that. Either it is a right side heart or outflow tract anomaly, or left side heart or outflow tract anomaly. And color of SVC should be always reverse of this outflow tract. Okay, this is a pattern recognition. And this is a 3 vessel view, which I am telling you. Learning curve is easy, and this is a 3 vessel trachea view. And here also, like in 4-chamber view, there is a acronym PASSS. Here is acronym PAS, pass, in normal situation. And in abnormal situation, we will remember acronym NAS, number, alignment, arrangement, and size. If we describe from right to left, this is a small dot, slightly bigger dot, and a big comma. And from left to right, this is a pulmonary artery, ascending aorta, and superior vena cava. So this is specific arrangement, and you can see they are very snugly fit. Almost there is no space in between. So it is described as a juxtaposed vessel. If there is a space in between, then again there will be a hint of either outflow tract anomaly, mainly aortic, right side aortic arch anomaly. There will be a space. And sometimes in case of coarctation of aorta, the superior vena cava will be slightly away. This is a checklist which you can get at the end of this 2023 document. If you are starting this Vitiligo from Monday morning, then you should use this checklist, and then gradually everything will become at a spinal level, and there will be no need of this checklist. Thank you very much. I have cut short a few things.
Thank you, Dr. Mayank sir. We would like to have a group photograph with the chairpersons. दिल का मामला हमेशा से कॉम्प्लिकेटेड ही रहा है. थैंक यू मयंक सर फॉर मेकिंग इट सो सिंपल. एंड मूविंग टू द नेक्स्ट सेशन, कार्डिक anomalies diagnosed, then what next, by Dr. Professor S. Suresh sir. The chairpersons for this session are Dr. Brijesh Kumar, Dr. Rishikesh Surani sir, and Dr. Nayan Sadhu sir.
In place of Dr. Nayan, is Dr. Kishan Patel sir available? Kishan Patel sir? Okay, thank you. I request our technical experts to kindly get ready for the next demo.
Okay, so what we are going to do is, I'm not going to tell you how to diagnose the cardiac anomaly. We will understand that Mayank has made the diagnosis and the patient has come to you with the report or has gone to the next level. What to do with that report is what we are going to see. Some basic concepts of how we deal with a patient with a cardiac anomaly. We know that cardiac anomalies are the most common structural malformations and also a leading cause of neonatal mortality. The biggest advantage of identifying a cardiac anomaly antenatally is to know where to deliver and what are the immediate steps to be taken care of when the neonatal team will hand over the baby to the cardiac team. The cardiac team never takes over the baby initially. It's always the neonatal team which takes over the baby, stabilizes the baby and then sends it to the cardiac team. And identification patterns of cardiac anomaly in routine practice is one, somebody might have suspected anomaly and referred to another center, or as you are doing a routine scan for a targeted scan, totally unsuspected, no low risk women, you find a cardiac anomaly. Or there could be markers in early pregnancy, like for example, reversal of A wave in the ductus venosus or tricuspid regurgitation, increased NT, so on and so forth. So the moment the diagnosis of a cardiac anomaly is done, what is important is to try and come to a conclusion of what is the most likely diagnosis. Now, before the rest of the team is involved, the primary operator must ensure that this is the probable diagnosis that is there. I am saying probable because as you see more and more, you might pick up something more. Recently, we had a case where we found that we had documented the pulmonary veins very nicely, 4-chamber, outflow tracts, everything was normal. The right atrium was a little prominent, and that was what the referral was for. But we didn't find anything greatly amiss. Baby was born, did well. 1 month later, baby had some difficulty, and then they did an imaging and found that baby has got a partial anomalous pulmonary venous drainage, which was completely. We went back on our images, we couldn't find it. So we had to be prepared for surprises after birth. And when you say the team who is going to take care of baby, of course the referring OBGYN is the one who is going to lead the show by getting the information, and then we have a discussion with the pediatric cardiologist. Many pediatric cardiologists are now also doing fetal echocardiography, but some of them are very good in pediatric cardiology, but they actually cannot do fetal echo. So they depend on the fetal medicine to do the echo, take that information, ask for more information. So there's an interaction between the fetal medicine specialist and the fetal pediatric cardiac person. And why they do is they are looking at it from the point of view of how to manage the baby outside. And finally, it is they who are going to communicate to the patient about what is going to happen and how the baby will be managed. Now, in between, before even it goes to the pediatric cardiologist, the geneticist comes into play, because the baby will get delivered and handed over to the pediatric cardiologist or the neonatologist only if there are no additional abnormalities. Supposing there's a major genetic defect with that, the patient is going to terminate the pregnancy and the route is going to be taken as very different. So the geneticist also plays a role here. And when you do the counseling, it's probably one of the most difficult abnormalities to counsel, because you're counseling based on a lot of presumptions. One of the presumptions you are making is, yes, this is the diagnosis which you feel is the right diagnosis. For example, you think it's Fallot's tetralogy. Baby is born, it is double outlet right ventricle. And the difference between that is very, very fine. And the other thing is, at 20 weeks, you have seen the scan. The baby has a certain cardiac structure. And then when it evolves into 30 weeks, the pulmonary artery has become completely narrow, which was not there. So when you counsel at 20 weeks, based on the fact that there was forward flow in the pulmonary artery and the correction could be done, by the time the baby reached 30 weeks, the pulmonary artery has become quite atretic. Now the whole picture changes. So it's an evolving thing. So we need to give just the information that is possible to give at this time, telling the parents we have to, some conditions may evolve over a period of time. And this is very difficult for the patient to digest, because they want a decision to be made now. This baby will have a good outcome, then I'm willing to continue the pregnancy, otherwise I don't want to continue the pregnancy. And that's a very, very major decision for anybody to take. So we become responsible for that in a way. So fetal echo is a systematic process, delineation of the lesion, look for extra cardiac anomalies, pediatric cardiac opinion, genetic studies, and also plan management. So let's divide broadly into three groups. Some are very low risk. Let's say there's a VSD. Now, as long as there's no associated abnormalities, no chromosomal abnormalities, that VSD is low risk. There's not going to be a big emergency at birth, followed up. Some of the VSDs will close on their own, and some of them may require intervention. Then we have a group called moderate risk, like tetralogy of Fallot, TGA, CTGA, and AVSD, and high risk, like common arterial trunk, TOF with pulmonary atresia, complex TGA, DORV, HLHS. These are fairly high risk and require, the outcomes are also may not be as good as others. Some time back, we were talking about correctable and non-correctable cardiac anomalies. More recently, it has been shown there is literally no cardiac anomaly which you say is not correctable. Hypoplastic left heart, you can do a cardiac transplant. So to that level you can go, because that level is available. And if some parent wants to undertake that risk of going through that, then we have to be supportive to them. Now, when you look at associated abnormalities, there are some cardiac abnormalities have got, like for example, tricuspid atresia can have associated abnormalities. DTGA and pulmonary atresia, usually they are isolated. And any fetus with CHD needs to have a detailed fetal examination. Significant extra cardiac anomalies may be undetected or undetectable till later gestation. Example, GA abnormalities. And low threshold for repeat assessment. Suppose there's a heterotaxy, you can have an intestinal malrotation which you will not be able to identify accurately. So that also, so we need to probably repeat the scan. Also, potential for progression. For example, semilunar valve stenosis may progress in severity and evolve into functional atresia. Ventricular hypoplasia, hypertrophy, and dysfunction may result from outflow tract obstruction. And a very important dictum which you should follow, form follows function. Form follows function is very important in the heart. That is, if you want an organ to grow, that form, it has to be functional. I'll give you a classical example. of flow through the aorta in, let's say, in the hypoplastic left heart. There is no flow from atrium to the left ventricle, left ventricle. So there is no blood going through the aorta. So the aorta is not formed, it becomes atretic. So similarly, pulmonary artery in TOF, if the flow is not enough through the pulmonary artery, it will become small, narrow and become atretic. So if you want the pulmonary artery to become big, blood should go through that. So form follows function, and that's why these anomalies evolve over a period of time. Now, AV valve regurgitation like tricuspid regurg, Epstein's anomaly may progress, resulting in progressive cardiomegaly, high drops, and also intrauterine death. Except this condition, very, very rarely intrauterine death happens because of a structural cardiac anomaly. So Epstein's anomaly is different. It can go into massive size right atrium and then go into cardiac failure and die. Even then, there's a lot of tolerance to it, and so VSD, AVSD, all these things, baby will not have intrauterine demise. That's something which is good to know. So risk of IUFD is low in sinus rhythm with good myocardial function with no AV valve regurgitation. Now let's look at genetics. 19% have extra cardiac associated anomalies, genetic abnormalities or syndromes, conotruncal defects such as tetralogy of Fallot, truncus arteriosus, interrupted aortic arch, 22q microdeletion syndrome is there, and this is something we should do routinely and ensure it is not there. Now, suspected trisomy 21, 40 to 60% chance of associated CHD. So, that's why when there's high risk for T21 or you diagnose T21 by NIPT or doing an invasive test, you have to do a detailed fetal echocardiogram for that baby. Left heart obstructive lesions, that HLHS, Turner syndrome is associated, and DTGA has the lowest prevalence of associated abnormalities. So, counseling, of course, discussion of amniocentesis. Now, what's your approach? History, we need to take a 3-generation pedigree. We always do that once there's cardiac anomaly. Antenatal history of drugs, infection, maternal disease. So, we found this patient had a cardiac anomaly, and then we found she was on lithium, and she didn't reveal that to anybody because she was having a psychological disorder, and she was on lithium for a long time. There was another patient who had epilepsy, and for that they were having anti-epileptic drugs. These are very strong reasons for teratogens, especially for cardiac, and so we need to take a proper history. Sometimes the first time you take the history, you will not get the answer, but a second time you take the history, slowly the information will come. Similarly, revealing of family history. Because the recurrence risk for cardiac anomalies run in families is quite high. So when you ask, because the husband does not, or the wife does not want to reveal that anyone in the family had a cardiac problem to the husband, and it's also vice versa. So they will keep this family information as secret. But you keep on asking them slowly, individually, you work with them individually, you'll find information there. The other thing is parental exam. So once there is some cardiac defects, we go and look at the parents. Undetected defects will be there, so which we can come to light. And phenotypic characterization is very, very important. So what are the available tests? Of course, chromosome is the most common. FISH, BOBS. BOBS actually means backs on beads technology. Microarray, single gene. You have Sanger and NGS, and also pre-implantation diagnosis can be done for some of them. And in molecular sequencing, you have a whole list of tests which you can do, and whole genome being the highest level test that can you do. But there are specific panels, varies from lab to lab. The geneticist must choose the right test for the right patient. Blindly doing tests is not going to help. Anticipated neonatal course and outcomes, medical, surgical, catheterization. So intervention surgical, maybe open surgical, or they could do percutaneously. They could do, for example, closing of ASD and VSD can be done percutaneously now. So prostaglandin for duct-dependent lesions, severe TOF with pulmonary atresia, HLHS, interrupted aortic arch, so on and so forth. counseled on multiple, to patient to be counseled on multiple team members being present in the delivery room. So the delivery room concerned people have to come and take charge, and also the need for nursery and ICU care. Now, most important, modifications to diagnosis may be made after birth and surgical plans may change. You might have counseled for one particular problem. This is the way it's going to happen. They're all thinking that day 3 or day 4, the baby will be operated and the neonatal echo will be done, and the pediatric cardiologist will say, well, nothing to be done now, we'll wait for some more time. Or they'll say, this can go on, you can do surgery after 3 or 4 months. Then at birth, they will say, no, surgery has to be done now. So it's especially, for example, aortic coarctation. Suddenly the narrowing is there, the pulmonary pressure is increased, and then you might have to do it immediately. So when I saw the picture, expectation was reality. Nothing is more further than the truth. Expectation is different, reality could be very different. So after the initial consultation, follow-up visits may include consultation with pediatric cardiac surgeon, neonatologist, geriatrician, and social worker. Now, 85% of CHD reach adulthood. So this is a gross macro picture. Okay, long-term survival, 95% for simple CHD like ASD, VSD, 90% for those with moderate severity, and 80% for complex lesions, TGA, truncus. And because today technologically we are far advanced than before, neonatal surgery, newborn surgeries are being done, experts are available, the outcomes are far better. And increasingly it has been shown that antenatally diagnosed cardiac defects also can cause developmental delay. So there is a in utero hemodynamic changes which are there, which can cause functions later on. So which is something we can't counsel for, because we really don't know exactly what to say in that situation. So let's look at some common problems: AVSD, TGA, TOF, and maybe right aortic arch. So here's a case 1. So it's a very typical picture of AVSD. You can see a central single valve and so single orifice which is there. That's your AVSD. And then we look at the outflows, which are okay. The final diagnosis was atrioventricular septal defect with common atrium, balanced ventricles, novel-related great vessels, normal rhythm, no other structural defects in the fetus. So this is what we have concluded from the scan. Now, AVSD could also be unbalanced, as you see here, when it is associated with complex defects. Isomerisms are more common, and DORVs are common outflow defect. So additional features for prognostication. So what am I going to do? So we look at situs, size of both ventricles, more subjective assessment. We are not going to do the measurement of the ventricles and say this is 2 to 3 millimeters and this is 2.5 millimeters. It's not just subjective, whether it's they are concordant or discordant in size. Outflow anomalies, aortic arch caliber, rhythm, and common AV valve regurgitation. So what are the associated cardiac problems here with AVSD? 40% of fetuses will have trisomy 21. So that's the first thing we'll rule out in any AVSD. 10% other chromosome anomalies. 40% of fetuses with AVSD have had right or left isomerism. So that's another issue. So fetuses with left atrial isomerism are more likely to have associated complete heart block and left ventricular outflow tract obstruction. These fetuses with left atrial isomerism and AVSD have relatively high mortality in utero, thus accounting for the much lower incidence prenatally. So AVSD by itself, okay, AVSD can be corrected. But if you rule out all this, it passes through all these filters, then you have an isolated AVSD which has a good outcome. So this is where our challenge is, trying to see whether this condition is isolated or associated. So what do you counsel the patient? So we explain major cardiac defect, other structures are normal. Around 45% will be associated with chromosomal abnormalities. So recommended amniocentesis for karyotype and fish. Postnatal surgical correction is available. Timing of surgery will be around 1.5 to 3 months of life. Within 6 months, an antenatal follow-up, interval growth, cardiac assessment that needs to be done. Now, the perinatal plan. Sorry. No, the last one just okay, doesn't matter. So case 2 is 26-year-old, married for 5 years, gestational diabetes on diet management, of course. FTS trisomy 21 combined risk is 1 in 1 lakh. Target scan echo at 23 weeks. And what we saw at 23 weeks, because we did this is the first trimester scan. I will explain this to you what just go for the anomaly. It was a right aortic arch with left ductus arteriosus with aberrant right subclavian artery. Rest of the fetus anatomy was normal. So it was a right aortic arch. So how do you counsel a right aortic arch? Now it's it becomes a sort of a conotruncal anomaly. It forms less than 1% of CH3. 25 to 30% may be associated with 22q level. So the moment you have something to do with the outflow tract, which we otherwise call as conotruncal anomaly, we look for 22q microdeletion. With left ductus and ulcer, postnatal vascular ring is also more common. So postnatal, when there's a vascular ring, when there's a right aortic arch with left ductus, it goes around the trachea, and sometimes if there's an aberrant left subclavian artery, it can constrict the trachea and have respiratory problems. So surgical treatment matter. So this baby postnatally we followed up with an NSC for 1 day. Postnatal echo confirmed the antenatal finding. Baby at present doing well. So no intervention was done for the baby. At 8 months, the right aortic arch with anomalous left subclavian artery, no other defect, normal ventricular function, no pulmonary artery hypertension. So the baby was just left alone. The things are going on. There was no need to go and correct that as long as the baby was asymptomatic. So in that case, once we excluded chromosomal and also 22q, we were able to reassure the patient that some of them will require treatment, some of them may not require treatment. This fell in that category. So this is the third case where at 19-20 weeks, you can see what baby has. 4th baby looks normal, but you see outflow tracts. There are 2 parallel outflow tracts with it. You can see both outflow tracts are parallel. So the moment I see both parallel outflow tracts, what I'm going to see is what happens to the ventricular septum. For me, that's a very, very important finding. So you can see the interventricular septum is intact. So parallel outflow tracts, intact ventricular septum. Of course, we are going to make a diagnosis of the transposition of great vessels. So here you can see in the outflow, you can see a single outflow. The other outflow, you see a single vessel. The other outflow is just behind this. They are overlapping against each other. Even though they are present, they are parallel to each other. That's why you are not seeing that. So TGA with intact spectrum. The moment you say TGA with intact spectrum, what is going to happen to this baby after birth? It's got a very low association with chromosomal abnormality. So on that we can be fairly reassured. But what is it that's going to happen to the baby after birth is the importance of having a VSD in this case. So correctable cardiac defect with good surgical outcome. Direct testing is just optional. Need for serial follow-up. And planned delivery in a tertiary care unit in ICU and cardiac referral. Need for postnatal prostaglandin infusion. We want the ductus to be open for this baby till the cardiac surgeon can take over, because this is a duct-dependent lesion. So any duct-dependent lesion will require absolute immediate neonatal care to keep stabilization with the prostaglandin infusion. So we did the follow-up in utero. KT with Bobs are normal, growth normal, no new cardiac findings were there. And postnatally, the mother was admitted in a tertiary care hospital, equipped with pediatric NICU, delivered at 31 weeks due to PROM. The most important thing here, we never go and try to deliver this baby in a hurry, because the more premature the baby is, the more difficult it is to handle the cardiac status postnatally. So this baby had to be delivered at 31 weeks because she had PRO. Otherwise, there is no indication to go and deliver this baby early in utero, because everything else is quite all right. So balloon atrial septoption is done on day 2. and then underwent an arterial switch operation after 3 weeks. Postnatal echo after 4 months showed there was no residual ASD PDA, baby alive and healthy and doing quite well. So even though it was premature baby, did well. So that just to say, this preterm baby also had a good outcome. So TGA is something we can tell the patient it's a completely correctable anomaly. In fact, there was a patient with TGA who wanted to terminate the pregnancy. I said, why are you terminating the pregnancy? She said, I can't afford cardiac surgery. Then I actually offered her to pay for the cardiac surgery, whether she'll keep the baby. She agreed. So we paid for the cardiac surgery. Baby was admitted in a government hospital, delivered and taken to the cardiac surgery, operated, and the baby is actually doing very well today. It's almost nearly 15 years ago. So it's very important because that particular life, we don't know what that person, that child may become the president of India. We don't know, isn't it? So every life is important, and we are here to help them to do that. So now TOF. Now TOF is a very different anomaly because of the spectrum of presentation. Tetralogy of Fallot actually there's overriding of aorta, and there is pulmonary artery is narrow. The amount of overriding can change, and the overriding can change so much that ultimately it looks like almost look like a DOR, right? So main pulmonary artery to aorta ratio normally is less than 0.6. Pulmonary artery to aortic valve ratio, pulmonary valve Z scores. Now the cardiac measurements which have been there, we've got Z scores for all, including valvular measurements, orifice measurements, everything. But believe me, it is the most irreproducible biometric parameter in fetal because it's a continuously moving organ. At which point you are freezing? Are you freezing when there's systole? Are you freezing when there's diastole? Which is the exact point you're freezing? And these are in few millimeters. And a few millimeters caliper mark, you'll place it a little bit away, it will be more or less. So unless it is striking to the eye, it is very, very difficult to do that. And pulmonary artery flow velocity is not reliable if very high to suspect restricted VSD. So a lot of issues are there still in the diagnostic part. So when you have tetralogy of Fallot, the parameters to be measured, RVOT measurements, pulmonary valve, main pulmonary artery, branch pulmonary artery, LVOT, aortic valve and ascending aorta, and flow dynamics to be monitored. All we want to know is there antegrade flow in the pulmonary artery? That's all I want to know. Is there forward flow and is the flow generous enough? So here you can see a very high velocity stenotic flow in the pulmonary artery. And then ductus arteriosus is normal. So this one case at 27 weeks, PA aortic ratio is 0.74. There was no ductal reversal, and postnatal well baby, pink tetralogy of Fallot, and elective surgery was done, did well. Whereas this case, what happened is this baby postnatally had a small pulmonary annulus. They had to do a BT shunt followed by correction later. So again, same condition, two babies, two different approaches. And to be very specific about this to a parent antenatally can be very difficult. So which one which will evolve into is very difficult. So this is another case where you can see looks absolutely normal. 4-chamber view, both the valves are seen, the interventricular septum, the LVOT. She was screen positive 1 in 90, but she refused direct testing. So target scan 20 weeks normal, full term normal delivery. Baby had dysmorphic facies, karyotype showed Down syndrome. So 1 in 190, refused invasive testing. But there was a muscular VSD, and this muscular VSD was not seen on the ultrasound. Okay, and needed surgical closure. Many VSDs need not require surgical closure, but this baby required surgical closure. So when in doubt, we have to wait. So here's the first trimester baby. You can see the tick sign, which is very nicely seen, and also the inflows which are there. Early target scan at 17 weeks showed this picture. Apparently, 4-chamber view looks normal, but if you carefully look at it, so this is your spine, this is your aorta, so this is your left atrium, and this is your supposed to be your left ventricle, but we saw the moderator band in the left ventricle or left-sided ventricle. So then we had to label that as the right ventricle. So obviously it was a CTGA, with intact shunt. Corrected TG8 was there, inversion of the ventricles was there, and very easy to miss it if you're not very careful to see why the moderator band is on the left side ventricle instead of the right side ventricle. So this was like this we look at these. We given you the examples because each one we counsel the patient in a different way. But now come to cardiac anomaly and timing of delivery. Now, induction of labor or elective cesarean section before 39 weeks of gestation is not recommended in the absence of standard maternal and fetal concerns about well-being. So, indication for delivery should be a maternal indication for delivery or fetal distress. If there is none of these indications present, the baby should go to full term, because then it's much easier to handle that baby outside. And even early term delivery has been associated with worse outcomes after neonatal cardiac surgery, right? So mode of delivery, vaginal delivery can be done. No need for cesarean section, okay? Only for obstetric indication, and also single ventricle. If there's a single ventricle, then baby will find it difficult in vaginal delivery. The team should be available, and a team is aware of the postnatal plan. So what about specialized delivery room care? Is recommended in conditions of detransposition of great arteries, sustained or uncontrolled tachyarrhythmias with heart failure or hydrops fetalis. Specialized delivery room care is reasonable when there's HLHS with restrictive intact septum, because the whole thing is, should you transfer this woman in utero, this baby in utero, to a center where facilities are available, or can you deliver and transport it by an ambulance? That's where we have to do that. So complete heart block, low ventricular rate, cardiac dysfunction, hydrops, specialized delivery room care planning is also needed. Specialized delivery room care may be considered for TOF with absent pulmonic valve, Epstein anomaly, and TAPVR are obstructed. And where specialized delivery room care is not needed, in mild tetralogy of Fallot, VSD, ASD, shunt lesions, most duct-dependent lesions, controlled arrhythmias. So at the delivery room, you don't need to do anything. Just give neonatology. They'll take it to the NICU and do what is required. So in utero transfer to cardiac OB unit, stabilization at level 3 NICU, and then transfer. So this is the kind of decision we want to take. So to conclude, diagnosis of anomaly is you should strive to get at the most reasonable diagnosis possible, and two people can look at it and agree with the diagnosis. Extra cardiac genetic assessment. If there is uncertain diagnosis, simply wait and watch. Let's not have a fatalistic outcome for this. Team counseling and realistic estimates to be given, and we need to guide the family to informed decision making. Always remember, patients decide on continuation or discontinuation of the pregnancy based on the level of reassurance you can give them. Level of reassurance. And many medical professionals are not able to give that level of reassurance simply because it's a responsibility they have to take on. Tomorrow they become answerable if an adverse outcome comes there when a good outcome was expected. So it's a very fine balance, and I think what the patient needs to be told is, this is the limitation of the system, these are the cards we place on the table, then you can take a call on that. Then immediate question is, what will you do if it was your own baby? That's what the patient will ask you. And well, I said, my thought process about a baby is completely different from your thought process on a baby, because what you feel about your baby is personal to you, and what I feel, it may be completely different from what you think. For me, as a medical professional, every life must be saved. So I will give the best chance to what is available. But that may not be the same thought process which you have. So we have to have it's a tightrope walk as far as cardiac anomalies are concerned. But I think in most cases, we will be able to achieve it. Thank you.
Thank you, sir, for giving such a vivid knowledge on topic. This is for sure that we will be able to counsel our patients definitely better on this topic. And we have seen our patients, we have villages who are not able to take the risk of operation or not able to take the babies to the higher centers like Ahmedabad. They tell madam इससे तो गिरा ही दो, कहाँ हम लेके जाएंगे इतनी दूर दूर ऑपरेशन कराने के लिए. But definitely after listening you and sir, we'll be able to counsel such patients much better. Now moving on to next session, we'll be having demonstration of the fetal heart scans by Swati Thakkar ma'am and both the sirs. Moving on to the demonstrations.
Before that, I would like to request the chairperson of previous session to have a small photo with the faculty.
Can you screen loud? Okay, Dr. Swati, if you are able to hear me, you can start systematically. Are you able to hear me there?
Yes, sir, I can hear you. Am I audible?
Yes, yes. Please start systematically.
Okay. So we will be focusing mainly on the heart. So before starting, we'll see the presentation of the baby. So this is cervix here, and the presenting part is cephalic. So the baby is in a cephalic position. So now let us start with the situs. So as I said, we take the situs in 4 images. This is stomach, the heart, apex of the heart on the same side, is the stomach, the presenting part, and the thalami on spinal side. So this is situs solitus, cephalic presentation. Now let us move on to the heart.
So what you notice immediately from general setting, she shifted to the cardiac setting.
Yes, and a box zoom, single focus, as sir had described, and always take clips so that you can select the best image you want to take. Now measuring the cardiac axis.
You can see their VSD like artifact.
Yes,
That is a echo dropout.
Yes, this
Don't worry. You remember my disclaimer.
Yes, I do remember. Okay. So for cardiac axis, an imaginary line from the intraventricular septum and a line from the spine. And so the cardiac axis here is 43.52 degree, which is normal. Anything between 45 plus or minus 20 is normal cardiac axis. Now the 4-chamber view. Okay, so there are so many informations hidden in the 4-chamber view.
Please decrease the gain slightly.
Yes. Okay. So in 4-chamber view, we are supposed to label 4 chambers. So here you can see 2 pulmonary veins. Here is the moderator band in right ventricle. Crux. Here you can see the offset. The tricuspid valve is bit on the upper side and mitral on the lower side. So the 4 chambers are left atrium, left ventricle, right ventricle, and the right
atrium. Here you can see the descending aorta, which is bit on a left side. So that artifact has gone now. There is no VSD.
Yes, no dropout now.
Yeah.
Ma'am, what was that frame setting Mayank sir was telling? Frame rate and all.
Sorry, sir.
Go in general setting and show frame rate, and then go in cardiac setting and show frame rate. So on right side upper corner you can see that 22. So for cardiac it should be more than 40 ideally. So moment she will switch to cardiac setting, see that is a 55.
Yes. Okay, the baby is changing the position. Okay. So say from abdominal section, as sir said, whichever position the baby may be, it is very easy to take 3 vessel view and 3 vessel trachea view.
See, she is not doing any magic and getting 3 vessel view. So there is no need of any magic.
This is stomach. I am going towards head side without tilting or without shifting my probe. This is 3 vessel view. So the larger one is the pulmonary artery.
Artifact.
Yes.
Dr. Bayuk is telling regarding pericardial effusion. So go to 4th chamber and show if there is artifact.
Yes. Let me show you the clip I have stored, sir, for 4-chamber view. Pericardial effusion.
Yes,
if you are
right
talking
side,
about
right
this
side
one,
upper, right side upper, yes.
Yes. So
measure that.
Yes. Okay.
So as I told in guideline, 2 millimeter, it can be artifact due to overangulation of a probe. So don't worry.
Okay. Since the baby has changed the position, I have just stored few clips few minutes back. So from 4-chamber view, if you tilt your probe towards left side, you'll get to see the left ventricular outflow tract.
Freeze and show the appearing and disappearing of aortic valve.
Yes. So this is disappearing of the aortic valve. The aortic valve is right here. And this is appearing of the aortic valve. So disappearing and appearing. So to be oriented, this is the left ventricle from where the aorta is arising. This is left atrium and this is right ventricle. So this is our left outflow tract.
Septoaortal continuity.
Yes. And this is a septoaortal continuity. Interventricular septum and aorta, the continuity of that.
Please move.
Okay. So again, from 4-chamber view, if you turn your probe tilt your probe towards right side, you will be able to see the right ventricular outflow tract. Here is the pulmonary valve. So this is the main pulmonary artery. These are branch pulmonary arteries. And this is aorta.
Ductus. Long is ductus.
Yes, the long one is ductus. And this view also is called a cup and saucer view.
If you have stored a 3-vessel trachea view, please show with color,
Yes.
without color.
So this is 3-vessel trachea view. Pulmonary artery, aortic arch, superior vena cava, and this is anechoic structure, which is trachea.
So we have to move a little towards cranial direction
Yes.
after locating 3SL view.
Yes, yes, sir. So this is 4-chamber, 3-vessel view, and if you're going towards cephalic side, this is cephalic side, you will get 3-vessel trachea view. And now with color. As sir said, both should be in an equal color.
Okay, Dr. Swati, thank you very much. Pooja, thank you very much. Jayesh, thank you very much.
So these are just images I had stored, 4-chamber and arch view in color and outflow tracts in color. Okay, thank you so much.
What a lovely demonstration. Let us move ahead with the conference talk, and the next topic is what we should know regarding twins pregnancy by Dr. Professor S. Suresa. To chair the session, I would like to invite Dr. Nidhi Patel ma'am, Dr. Nirav Modi sir, Dr. Jyoti Sorathia ma'am. Nirav Modi sir. Okay. To assist Jyoti ma'am, I would like to request Dharmi ma'am to please join her. Thank you. There was a small lucky draw and it is going inside the hall. I would like to name once the draw is done.
Okay, now to say a few things about twins. How many of you feel twins is double trouble? How many of you feel twins is double delight? No one? So we want to make double trouble into double delight. Because if we know about them, then we certainly can try to get the best out of them. So we'll understand diagnosis and number of fetuses, establishing viability. We'll see how to triage twins in early pregnancy, follow-up protocols, what happens when there's discordancy between the twins, how to investigate complications of monochronic twins, and treatment opportunities and success rates, and when to deliver. So this is how we'll do. So I said we'll understand, but now I'll say we'll attempt to understand, because twins are very complicated. Okay, this is a case, 28-year-old ovulation reduction at 5 weeks. And the second case is 26-year-old spontaneous conception at 4.5 weeks. How many fetuses are there? Number of pregnancies? 2. The first one here, single. Okay. So when they came at 9 weeks, that turned out to be a dichorionic triamniotic triplets, and this turned out to be a monochorionic twins. So simple rule, don't diagnose the number at this stage. That's all. Okay. So rule 1, number of gestational sacs is not equal to the number of fetuses. Okay. Prior to the appearance of yolk sac or fetal pole, it is difficult to exclude the possibility of monochorionic twins. In practice, majority of monochorionic twins which you see in the 11 to 14 week scan, they have been diagnosed as singleton in early pregnancy. Majority, you'll just see that, because especially when they are confirming pregnancy, confirmation of pregnancy by gestation, they say there is a pregnancy. But then suddenly we tell them it's twins, they're taken by surprise. Rule 3, number of fetuses is equal to the number of cardiac activities. So if you see 2 heartbeats, then there are 2 babies. Now number of yolk sacs is not equal to is equal to the number of amnions. So if you want to diagnose amnionicity, you count the number of yolk sacs. There are 2 yolk sacs, there will be 2 amnions. The only rule 3 is the number of fetuses is equal to number of cardiac activities. The only exception to that rule is monochorionic twins with trap sequence, where the acardiac twin will not have a heart, but it will grow in size and the other baby will be, cardiac activity will be present. Now rule 5 is suspected momo twins. When there's a monoamniotic twins, always confirm amnionicity by transvaginal scan. Transabdominally, never diagnose momo twins. You have to do transvaginal, make sure, increase the gain a lot, and before you diagnose, because you can see that this baby, by transvaginal scan, you can see the 2 amnions there. Oops. So this looks like a single sac. If you go all the way here, it can look like a monoamniotic twin, but carefully when you look at it, you can see the 2 amnions there. So next is triaging. First, you must take history. Detailed history. I'll tell you the reason for taking the history. Second is chorionicity. Third is crown rump length, nuchal translucency, structural anatomy, and then aneuploidy. So when you look at a twin pregnancy, the background history of diabetes, hypertensive disorders, autoimmune disorders, then this patient needs to seek subspecialist care immediately, not after they get into complications. Uterine malformations and there's prior loss, supposing there's a bicoordinate uterus and suddenly you find a twin pregnancy, if there's diabetes, of course, you optimize the glycemic control. You can consider in uterine malformations whether elective reduction to a singleton for better outcomes. Now, here's a case study. Mrs. Y comes with the below ultrasound report. How happy are you? Twin intrauterine gestation 9 weeks, both fetus is viable. Fetus A CRL 2.2 and fetus B 2 centimeters. No adnexal pathology. Are you happy with this report? No chorionicity. Okay. So, dichorionic intrauterine twin gestation at 9 weeks, both fetus viable. So, chorionicity is important. There are no twins. Only MC or DC twins. So, never use the word twins alone. Always qualify them. Now, when you want to triage for chorionicity, above chorionicity is zygosity. Whether it was single zygote or two zygotes there. So, dizygous pregnancies are always dichorionic. Dizygous pregnancies are always dichorionic. Whereas monozygous pregnancies, because of early splitting, nearly 29% of them you can have DCDA. So, single monozygous pregnancy can become dichorionic. Dizygous will always be dichorionic. And of course, when the splitting of the egg happens later, it leads to monoamniotic twins and also conjoined twins if the splitting occurs between day 13 to 16. So, in your early part, we are going to sort out a lot of things. As far as ultrasound is concerned, we can only predict chorionicity and not zygosity. Chorionicity, if I find two babies of opposite gender, then I can say dizygous. If they are same gender, I cannot find out. And if I find out the gender, I will go to jail anyway. So, when you look at perinatal outcomes based on chorionicity, monoamniotic twins has got the maximum mortality and morbidity, adverse outcomes. Next is MCDA and DCDA have got better outcomes. So, that's why we need to do chorionicity. Now, how are we going to identify chorionicity? Dichorionic twins, classically the lambda sign, two separate placentae. One placenta on the anterior wall, one placenta on the posterior wall. I am not going to bother about lambda sign. When both placentae are on the same wall, lambda sign is going to help me with a sensitivity of 97.4%, specificity of almost 100%. So here is the lambda sign, very typical, and the T sign for monochorionic twins got a sensitivity of almost 100%. Now this is the opportunity we have at 11 to 12 weeks, and we should not miss this opportunity. But here's a patient who comes, twin intrauterine gestation at 12 weeks, both are viable, fetus A 55, 54, to review at 18 weeks to determine chorionicity. This is the report which has come. What should you do? You have three options. Refer now to determine chorionicity. Recall at 16 weeks and the baby is bigger, so it's easier to check chorionicity. Routine target scan at 20 weeks when we can check everything then. When do you want to verify? Because they have done the 11th week scan and they themselves have said to review chorionicity. Not that they didn't look for it. They looked for it and said, I'm not able to find out. Come back at 18 weeks. What is your choice? Pardon? Choice 1, 2 or 3? Choice 1. So that means your colleague was not able to identify and you are confident that you will be able to identify. Let's say the report comes from Mayank. Then what will you do? Will you say, no, come now? So, irrespective of who has done the scan, you have to refer now to determine chorionicity. You cannot postpone chorionicity to the next to 16 weeks or 18 weeks. It must be determined at that time. That's the rule. So, here's an MCDA twin with unossified nasal bone. At 11 weeks, it was reported as DCDA twins. At 11 weeks, it was reported as DCDA. FTS low risk. NB was not included. She comes at 21 weeks for target scan. It was MCDA twins and one baby has unossified nasal bone. A and B both have unossified nasal bone actually. Now what? This is not the complication of twins, okay? Somebody has reported a DCDA. We now know it is MCDA. You can go and argue, you only said 11 weeks is 100% and 21 weeks is not so accurate. So how are you sure now it's MCDA? I am very confident it's MCDA. But yeah, we look at past images, we came to a conclusion of the MCDA. Now 21 weeks, both unasphared nasal bone, how are we going to approach this? So I'm telling you, these are all decision making challenges we face. We'll address that as we go by. Now next is the naming ceremony. Twins have to be named then and there, not after delivery. Okay. Either call them as twin 1 and 2 or call as A and B. Most commonly A and B. Why they should be named is these are going to come back for follow-up. And when they come back for follow-up, you need to do biometry for both. And you need to plot the biometry for that baby in its own curve. So you do the biometry of one and next biometry abdominal circumference, you put the B abdominal circumference. Third time you again put the A, the graph will go like this. And you don't know what's happening. So very important. So labeling on twins, and you have to maintain this label throughout the pregnancy. And that's where the tough thing comes. Where as it grows, the uterus can rotate a bit. What fetus was there on this side can go on that side. Very, very difficult. But having said that, barring monoamniotic twins, both MCDA and DCDA twins, you will be able to label and maintain the labeling by following certain rules. 85% of twins will have a side-to-side orientation. By nature itself, it happens like this. One baby will be on the left, the other baby on the right. 15% of them will be cephalocaudal. So here, this is a typical cephalocaudal disposition. So this is one baby, there's a membrane there and that's the other baby. Here it's a side-to-side. This is the most common, followed by this one. So you can actually draw a picture and keep it. This is how the orientation is. Secondly, you can look at the placentae. And thirdly, you can look at the umbilical cord insertions, where it is inserted. These are all things that will help you to identify which twin is which. Now, you also have to remember there's a phenomenon called the perinatal switch phenomenon. Now, so here is a typical side-to-side orientation where the amniotic membrane is attached here. That means this is the one which is closest to the cervix. So fetus A will be delivered first and fetus B will be delivered second. So the baby comes out first. But in a perinatal switch phenomenon, the B can come out first and the A can come out second. So what you labeled as A and B, you must be able to identify them after they deliver also. Isn't it? You can do by various means. One is the estimated fetal weight of the babies. One baby, there'll always be some discordance. You can sort of look at it that way. Or at the time of scan, just before delivery, you know which baby is coming out. You can do it like that. Right. Now, after birth, whether you label B as A or A as B, nothing is going to matter unless they are complicated twins. And when they are complicated twins, it will be quite evident. Now, next is first trimester, CRL, NT and anatomy. You divide them as DCDA and MCDA. They could be concordant or discordant for either. Similarly, MCDA could be discordant or concordant. For either means, could be discordant for CRL, could be discordant for NT, could be discordant for anatomy. Even though MCDA we call it as monozygotic twins, structurally they can be different. You can have one baby with a structural anomaly, the other baby normal. Genetically, they can be identical. That is, one is Down syndrome, the other can be Down syndrome in a monozygotic twin. But structurally, they can be different, right? So we have to do that. So crown rump length and dating. Now, in a twin pregnancy, crown rump lengths can differ in size between the twins. So in dating the pregnancy, it becomes a bit of a confusion which one to take. That is, should I use CRL of the larger twin or the smaller twin? And by default, we always use the CRL of the larger twin for dating the pregnancy. Because it's very unusual to see overgrowth of a baby at that stage. But growth restriction can happen even in the first trimester. So pathological entities can present in the first trimester. In overgrowth is not common. So we use the CRL of the larger twin. Now ART pregnancies, we always use the ET date or BT date. Now what is the reason? When there's a discordance for it, what is the degree of difference you require before you call it a discordance? Greater than 10% discordance, if there's between the CRL, early fetal loss, it's a relative risk is about 1.9. Greater than 15% discordance, the early fetal loss rate goes to 4.8 relative risk, and the risk of birth weight discordance is of more than 25% is 6.8%. So generally, we consider more than 15% discordance in the size of CRLs as significant. We start labeling them as discordant twins. Okay, and in an MCDA, we find again more than 20% discordance. The fetal loss rates before 20 weeks and less than 24 weeks is quite significant. So 15 to 20%. So here you can see the two growth patterns, one baby growing small, the other baby growing normally. Right. Now aneuploidy in twins. When you want to screen for aneuploidy, chorionicity is absolutely essential for a simple reason that the way you report on aneuploidy screening in monochorionic twins is different from dichorionic twins. By looking at the report from the lab, you can quickly understand whether this lab knows its job or no. Very simple, and I'll tell you what you should look for. Now, in DC twins, both normal or one abnormal aneuploidy. It's very, very rare for both abnormal to be both to be abnormal. The risk of both babies having Down syndrome in a dichorionic twin is 1 in 90,000. So very, very rare. Whereas in a monochorionic twin, both can be normal, both can be abnormal, and one abnormal is very rare. That is called heterokaryotype. That's very, very rare. Right? So now, aneuploidy screening in twins, ultrasound-based screening. You can do NT, age plus NT plus NB, only ultrasound without biochemistry. You get a 70% detection rate, feasible in all settings. If somebody asks for low resource setting, yes, this is possible. You can do combined screening with PAPE, HCG, NT and NB, 85% sensitivity, and the key driver here is NT. NT is the most important. And non-invasive screening can also be done for twins, 98% sensitivity, slightly higher test failure rate as we spoke in the morning. Then looking at anatomy, we follow the same singleton rule to the twins also, the rule of two checklist. I'm not going to go through that. But we need to look at care pathways beyond the first trimester. Discordant DCDA, if there's a discordancy of DCDA, if there is an anomaly in one, then we can think of selective fetal reduction because you're doing it very early in pregnancy. Discordant NT, and you evaluate, then you can do query. Supposing NT is 6.5 on that side, you can evaluate that baby, do a karyotype or do a microarray, and then decide to do a fetal reduction. And discordant CRL, we do closer assessment and look at growth. And when the CRL is more than 20% discordant, this baby had 33 weeks LSCS, fetus B turned out to be growth restricted. So this baby was small right from the beginning and was small, but overall had a good outcome. But when the discordant MCDA, their outcomes are going to be slightly different. If there's an anomaly, okay, you contemplate management at 16. We don't go and rush and do anything about an anomaly in the first trimester in an MCDA twin, because you can't go and do fetal reduction by injecting potassium chloride in an MCDA twin. The other baby will automatically die. So we wait till it is 16 weeks, and when you come closer to 18 weeks, we can do radiofrequency ablation of one of the twins. So here's an anencephaly and a normal twin. We can do RFA at 18 weeks. In fact, one of my very first fetal procedures for more complicated twins is a lady from Ahmedabad, and Mike knows that very well. I still remember her name also. We did a bipolar cord occlusion for a anencephaly twin with anencephaly with another normal, and then she delivered singleton baby. Now, discordant NT, again you evaluate. Now, NT interpretation in monochronic twins is very different, because when we calculate the risk for NT, which we will see shortly, you average the NT and give a final single risk only. Whereas DCD twins, twin A will have a separate risk, twin B will have a separate risk. In MCDA, there will be only one risk for the whole pregnancy because it is monozygotic twin and both are genetically identical, right? So, if the CRL discordancy is there in monochronic twins, we monitor for selective growth restriction. And selective growth restriction is different from the growth restriction of a singleton. Rules are different, treatment is different, management is different. So, we'll see that. So, once there's a high risk of aneuploidy screening in monochronic twins, what do we do? Screen positive if it is DCDA, then we do CVS or amniocentesis. In MCDA, amniocentesis is preferred over CVS. So, when you have an MCDA twin with a positive screening test, always go for amnio and not CVS. This is actually better because the representation of the CVS is can be there's a higher chance you might get mosaicism and other problems, whereas in amniocentesis you can be very specific. You do anatomical evaluation and you can choose either sample both sacs or only sample one sac. Right. Follow-up protocols. Okay. Now, how are you going to follow up at dichorionic twins? Dichorionic twins slightly different from singletons. Otherwise, other protocols are same. 11 to 14 weeks. Dating, labeling, chorionicity, screening for T21. Then 20 to 22 weeks. Detailed anatomy, biometry, amniotic fluid volume, cervical length is what we do. And we also don't know in a twin pregnancy cervical length how far it helps in preterm labor prediction. But then you call them, generally call them as 4 weekly, or you can get them at 28 to 30 weeks, 32 to 34 weeks, 36, 37 weeks, and then delivery, assessment of growth, amniotic fluid volume, and Doppler as indicated. So this is the DCDA. When you go to MCDA, the protocol is completely different. From 11 to 14 weeks, you have to get the patient every 2 weeks. Every 2 weeks they have to come. 16, 18, 20, 22, 24, 26, 28, 30, 32. Every 2 weeks they have to come. Even if they are going concordantly, because in MCDA twins, things can change dramatically within a week's time. What was absolutely normal, before they used to say up to 26 weeks, if there is no complication, is unlikely to have complications. And recently also we've seen a patient. At 30 weeks, everything was normal. At 32 weeks, she developed severe twin-twin transfusion syndrome. So we've had to follow up every 2 weeks. So in monochronic twins, every time the patient comes, we have to do Doppler. That is umbilical artery, middle cerebral artery, and also MCA peak systolic velocity and ductus venosus Doppler. We need to do all the three. Right. So by doing this triaging, we can separate these fetuses into those who require immediate care. MCDA discordant NT, trap sequence, DCDA with major anomaly, DCDA with discordant NT. Second is those who require close monitoring. MCDA discordant CRL NT, MCDA with anomaly, and MOMA twins. And low risk routine care when they are concordant. MCDA 2 weekly, DCDA 4 weekly. So this triaging helps you to put these patients into these categories. Now we go to second trimester. Now from second trimester onwards, DCDA twins follow the path of singletons. So we will exclude them from the story. We will now concentrate on MCDA twins only, MC twins only. So second trimester MC twins, what should we look for? And I wish that when you see MCDA twins reply, always ask for cord insertion site. You ask for it in the report to be put there. Where is the cord inserted? Central, marginal, or velamentous cord. And because when there's a velamentous cord, there's a higher chance of birth weight discordance and the selective growth restriction is much more common when there's a filamentous cord insertion. So that's you do. And you also look for, are the cords inserted very close to each other? So these are called proximate cord insertions. You can see these two cords inserted very close to each other. And this can happen in Momo twins. It can also happen in MCDA twins, because if this baby has complications, it's extremely difficult to treat that because the vascular connections are very close to each other. Now, what to look for in the second trimester monochorionic twins? 4 things. Liker, bladder, Doppler, heart. Okay, you look for liker each side, single deepest vertical pool. If there's a discordancy, more than 8, less than 2, that is oligopoly. More than 8, less than 2, it's oligopoly. Presence of bladder. When the bladder is present, look for the size. One bladder may be very big in size, the other may be a little small in size. But absent bladder on one, presence of a bladder on the other is what we look for. But when there's a discordancy in bladder size, be alerted that this is going into a problem of twin-twin transmission syndrome. Then Doppler. Now, what am I interested in the Doppler? 2 things. When there's a monochorionic twin, when there is an oligopoly situation, Doppler of the recipient twin ductus venosus. Because the cardiac overload is going to be high, and I want to know if the DV is becoming abnormal. Of course, the smaller twin, generally the smaller twin Dopplers will be normal, but in a severe growth restriction associated with TTTS, Dopplers can be bad in that Doppler. So we look at. Now, when I look at the heart, I will just look at visually I will look at the heart, whether there's cardiac enlargement or no. If there's cardiac enlargement or a right-sided right atrial enlargement, I am immediately alerted. I look for tricuspid regurgitation. So I know that there is a volume overload situation going on here, and this is a complicated twin. Right. Now, when there is a liker discordance between the twins, what are the conclusions I can come to? Because there are 2 sacs, both can be normal. One can be less and another can be more, or one can be less, the other can be normal, or one you can have different kinds of combination. So here, normal in one, oligo in the other, or reduced liker. So one is normal, single deepest vertical pool, like say 4 or 5. The other is 1.8. So what do you do? We think of anomalies, we think of growth restriction, and also premature rupture of membrane. Ask her whether she's leaking, whether it's there. So you rule that out. If it is normal and polyhydramnios, normal on one side, polyhydramnios on the other side, to rule out anomalies in that twin with the polyhydramnios sac, and or close surveillance for evolving problems, because twin-twin transfusion can evolve with first being normal poly, but then that become oligo over a period of time. Then poly-oligo, it is twin-twin transfusion syndrome. So when I say measurements, it's always less than 2 centimeters and more than 8 centimeters. Single deepest pool in each of these sacs. Now come to monochorionic twins and its complications. Several things can happen in monochorionic twins. One is growth, one can be small, the other is twin-twin transfusion, third is anomaly, and the other is twin anemia polycythemia sequence, and the other is trap sequence. Now, each of these needs a different approach in management. So, twin-twin transfusion syndrome is when there's a net imbalance of flow between the twins in oligopoly, leading to oligopoly. And supposing she's coming to you at 20 weeks, now the definition of polyhydramnios is more than 10 centimeters in the other sac and less than 2 centimeters in the donor sac. Right. Then we stage. Once you see oligopoly, we diagnose twin-twin transfusion. Are the bladders present? If bladders are present, it is stage 1. If bladder is absent, then it's stage 2. If abnormal Doppler, it is stage 3. And high drops in the recipient, it is stage 4. And then stage 5, of course, critically abnormal. This is just for us to give a guidance of how we are going to manage that. So once you... So what is the natural history? Now, you can have a stage 1 TTTS within 1 week it can go to stage 3. It is not like it will go to stage 1, then it will go to stage 2, then go to stage 3 like that. We can have a TTTS which is starting off at stage 3 only. So there's an abnormal Doppler, cardiac overload, so on and so forth. So it can change, and all this can change over a few days' time. So what is the treatment? Some cases of stage 1 at any gestational age. We do stage 1 means we generally do expectant management. The only reason why I will want intervene in a stage 1 TTTS is when there is maternal discomfort, cervical length less than 2.5 centimeters. Such cases I will go and do intervention. 10% of this will actually regress, 20% will remain stable with no intervention, and 60 to 70% will progress rapidly, so close surveillance is required. Now stage 2 and beyond, after 26 weeks, we only do serial amnio drainage. We do amnio drainage because once you cross 26 weeks, we don't do surgical procedures in utero because the fluid will become very turbid and very difficult to do the surgery after that, technically very difficult. Now between 16 to 26 weeks, stage 2, 3 and 4, we do fetoscopic laser surgery for closing the anastomosis. It is called a selective laser photocoagulation. And in stage 4, sometimes selective feticide by umbilical cord coagulation or radiofrequency ablation can be done. So here is a case study where she was referred at 30 weeks. Up to 24 weeks, everything was concordant. There was a discordancy in growth of 23%. Doppler was normal on both sides, and anatomy, there was fetus B had anhydramnios and some altered shape of the calvarium. So here are the Dopplers. Dopplers looked quite alright. It was stage 1 TTTS with a weight discordancy of 23%. You can see how the skull of the oligo baby is. So amnio drainage was done on day 30 plus 4 with biweekly follow-up. And then umbilical artery went from absent to reverse endoscopic flow at 33 weeks. And twin 2, the smaller baby, 1.2 kg, succumbed on day 12 of life. And the other baby now survived, is 4 years old. Now, when you do when you do fetoscopic laser between stage 2 to stage 4, it is done under local anesthesia. You identify the membrane and you identify all the anastomosis one by one. And about 70 to 76%, at least one survivor can be assured, and about 60% double survivors. Then what if one of the babies is small, but the Liker may be less in one, normal in the other? We call this as selective fetal growth restriction. And you diagnose it by when the estimated fetal weight of one is less than 3rd centile or less than 10 centile, AC less than 10 centile, discordancy more than 25%, and umbilical artery PI is abnormal. So the moment you see umbilical artery PI, the moment you see SFGR, I'm going to look at cord insertion. So here you can see a classical velamentous cord insertion here. So once you see a velamentous cord insertion, this means only this portion of the placenta is supplying this baby. The larger portion of the placenta is supplying the bigger baby. So this is called as placental territory sharing. The second thing that happens in this twins is you can see a large vessel here, and their blood is flowing back and forth in the same vessel. This is called as the arterio-arterial anastomosis. So blood from one goes to the other and then it comes back. And these two fetuses, the blood circulations meet somewhere in the middle there, and that's called as the hemodynamic equator. So it can get shifted to one side or shifted to the other side, and that actually decides how the Doppler will be. The umbilical artery Doppler changes are entirely related to the vascular architecture and not to placental dysfunction, which we see in a singleton pregnancy. So type 1 is where there's forward flow, type 2 is where there's reverse diastolic flow in the umbilical artery, and type 3 where there's intermittent absent and reverse diastolic flow. Now all this does not mean placental dysfunction. This means smaller area of the placenta, and this is entirely due to the artery to artery anastomosis which is happening between the twins. So I'm not going to rush and say, this baby is hypoxic, I want to deliver now. I'm not going to do that. So what can we treat? How can we treat this baby? We can do laser for dicoronization, making them as a dichorionic pregnancy, but that's extremely difficult, and we have not been able to do a single case so far, unless it's associated with TTTS. The other thing, you can do a bipolar cord occlusion, you can do, and the easier method, of course, is to do a radiofrequency ablation. We put a radiofrequency needle and then you ablate one of the smaller twin so that the bigger twin has a better chance. Then twin anemia polycythemia sequence. The reason why we should do MCA Doppler in all these monochorionic twins is in 1 to 5% of the time, nothing else will be wrong. Both Leica will be normal, baby seems to be growing well, but one baby will be anemic, the other baby will be polycythemic. That's called spontaneous TAPS. Post-laser TAPS is more common with nearly 5 to 13%, and we diagnose it by looking at the MCA peak systolic velocity of both the twins and difference between these two, and it's called as delta MCA PSV mom. If it's more than 0.5, then we know there's a TAPS. Management, of course, is expectant, intrauterine transfusion or laser. So here is a lady who comes and says, I'm 10 weeks pregnant, I have twin babies with no heartbeat in one, but baby seems to be growing in size. It's a very common way of referring a patient, saying twins with one missed abortion, but the missed abortion is becoming bigger in size. Then the diagnosis immediately on the phone without seeing the patient, you can say it is called trap sequence. These acardiac fetuses will grow. So acardiac fetuses could be monochorionic diamniotic, or momo twins, and this the bigger baby is called the pump twin, and the abnormal baby is called as the perfuse twin. So what do we do to treat this? We put in a needle at the hilum of the acardiac twin and do a thing called interstitial laser, or we can do radiofrequency ablation. Both of them have got up to 80% survival rate for the pump twin. Then, of course, monoamniotic twins. Momo twins at one point in time we were dreaded because of cord entanglement. The antenatal management is very controversial. Highest risk of IUD after 24 weeks was between 24 and 30 weeks, and about 4.3%. It reduced to 1% at 31-32 weeks. So if the baby escapes between 24 to 30 without any mishap, then the chances it will go to 32 weeks are much, much higher. And between 33 and 34 weeks, it doubled to 2.2%. So that means delivery of momo twins must happen between 31 and 32 weeks. That generally, even asymptomatic momo twins preferably delivered at 31 to 32 weeks. Or at least around 32 weeks or so. So cord entanglement is seen in all momos, but does not contribute to increased perinatal mortality rates, because it could be loosely attached cord. Sometimes it can be tight, it can untangle, can do a lot of things. Now coming to timing of delivery. Uncomplicated monochorionic twins, elective birth from 36 weeks, no increased risk of serious adverse outcomes. Continuing beyond 38 weeks increases risk of fetal death. So we do not want monochorionic twins to go to 38 weeks, preferable at 36. Okay, uncomplicated. Uncomplicated decedents, elective birth from 37 weeks, not associated increased risk of adverse outcome. Continuing beyond 38 weeks, increases risk of fetal death. So again, DCDA can gain one more week of 37 weeks, but MCDA 36 weeks. So monochorionic twins have a variety of complications. Remember, these complications are not exclusive. They can overlap with each other. You can have TTTS with SIUGR, TTTS with TAPS, SIUGR with TAPS. All kinds of combinations can happen. So you need to evaluate them very carefully and effective treatment to be done appropriately at the appropriate time. So evidence continues to evolve for management of TAPS SIGR, and management of discordant anomalies is by patient choice. Thank you.
Thanks a lot, sir, for giving detailed knowledge about the twins. Now we'll have the most awaited session of today's event, that is the panel discussion. I call upon the panelists, Dr. Mayank Chaudhary, Dr. Dhiren Thakkar, Dr. Himangiba Waghela, and we'll have the sitting arrangement also. Sitting arrangement. Okay. Okay. Well, sir. Sure. So after all this detailed knowledge what we have got today, we'll have a detailed panel discussion on decision making and when to deliver. So panelists, please come on the stage. Front row we have kept for the panelists. Dr. Sandeep Tilwani, Dr. Mohit Kaur, Dr. Rajesh Mewara, Dr. Shelly Chaya, Dr. Puneet Khatri sir.
Much time. We'll try to rush through what is possible. Oops. I think the project was feeling very tired. Shaking. Okay. So, for me to understand my panelists, we have fetal medicine specialist, we have obstetrician. Who's the obstetrician here? All. No, neonatologist. 2. And sir? Very good. Okay. So, let's do, I'm going to cut out all the preambles and other things. 33-year-old primary gravida referred for scan in the second trimester. According to her LMP, she is 24 weeks, but her fundal height appears to be 20 to 22 weeks. These are the parameters. Sir, I didn't get your name. Mohit, yeah. So, what do you think?
Sir, all growth parameters are below percentile. So, we'll have to label it as a growth restriction.
Okay. I think mic should be switched on.
Yeah. So, if AC and if fetal weight both are below third percentile, we'll have
Yes.
to define it as a fetal growth restriction, early FGR.
Okay. Mayank, would you call this as growth restriction?
Before that, I will ask past record if there is a need of date correction or not.
Okay. So, so LMP 22 weeks, ultrasound 18 weeks. You say you will not label it as growth restriction.
First, I will see the previous information. Dating.
So, on dating.
Yes.
So, you will not label it as growth restriction. You want the dating scan. So, to reconfirm whether it's correct dates, what are your choices?
Either go
Do
back.
you want to ask for the report of early scan? Okay. Or you want to correct the dates using the scan?
First option is good.
First option. Okay. And or you want a third option. Correct the dates using the current scan only if early scan is not available. Because everybody may not have the early scan. No?
So that is not a good option. Second option.
But if they don't have it, what am I to do?
I will
Then you
tell.
have to option. Or simply can we do rescan in 2 weeks where the dates are correct? In 2 weeks we can see interval growth. And if it's growing well, then I say, okay, probably it's a small baby. Which is the best choice here?
First one is best choice and last one is rational choice.
Okay. Okay. The third one is also a good choice. And then last one is not a choice I want. I simply don't want to keep quiet and say come after 2 weeks. She's already 24 weeks. So next is, of course, this is something we won't ask now. It's too simple to ask now. Let's move forward. So it's not a So 4 key questions. Okay, definition of a small baby. Is small synonymous with growth restriction? Best parameter to diagnose FGR. Best method to diagnose FGR. We leave out the first 3 because already we have covered in our talk. What is the best method to diagnose fetal growth restriction? You go by the ultrasound report, or what would you like to see? Best method to diagnose fetal growth restriction. Okay, growth curves. But how many in your routine practice, how many give you the growth curves? Everybody? Oh, very good. That means evolved already. Okay. But the moment you see a growth curve, a report comes to you saying that this is FGR. How you simply accept that report, or you decide for yourself whether it's FGR or no. You have to do some audit, no? Saying whether this is there or not. So what is the best method? Which is the parameter you look for?
Sir, if the first trimester scan is done,
Yes.
and the dating is corrected,
Yes.
at that stage, and in the second trimester scan we see lag of growth from that period, then
Okay.
If the lag is less than 10 centile or less than 5th centile, will definitely say it FGR. But if the dating scan is not done, then will not judge it as
Yeah, okay. So when the dating is done, AC less than 10 centile, estimated fetal weight less than 10 centile is what you do. Now we have gone through the Delphi criteria already. Then let's go to case 1, right? Now since the pregnancy 3 months, 2 miscarriages, and at present APL screen was done normal. She's already on ecospirin and referred for FTS at 12 weeks. At 12 to 13 weeks, this is the report. Sir, Mohit sir, can you say, are you happy with this report?
Sir, we need to have some information regarding first trimester soft markers, some structural structures of the
Okay,
fetus.
so in this case, we are actually looking for growth only. We'll presume that all the other things are normal. This is, because it's a growth panel, I'm restricting to growth. Ma'am, would you, see the patient has come to you with this report, are you happy with it? Or do you want anything more?
uterine artery Doppler.
Okay, so Doppler stage is uterine artery Doppler you want. These are the uterine artery Dopplers. Are you happy now?
It is high abnormal.
It's high resistance.
We'll take the mean of it. We'll measure the patient's blood pressure, past history of pre-eclampsia. No,
Okay.
she was not like
So
abortion.
the question is, do you ask for routinely uterine artery Dopplers for all patients?
In first trimester, yes.
Yes, it's come part of protocol, right? And for clinical practice, some interpretation has to be there. High resistance, low resistance, right? So Mayank, you want to take this? The
Mean PI is high as it is done transabdominally.
yes,
So mean PI is high as far as that measurement is concerned.
correct.
We will put all point together and we will see what is the final risk.
So that is a preeclampsia screening protocol. Sometimes we do screening protocol, we don't do it. But when we have a uterine artery high, next is do the blood pressure, at least do the blood pressure, because she's got 2 previous miscarriages also. Then she's already on aspirin, which is the only treatment. Only thing is she was on aspirin of 75 milligram. Are you happy with that? No. Because this case was from 10 years ago. At that time we were using only 75 milligram. Everything changed later. Okay. So we'll go move on. We'll go out to so she was reviewed at 16 weeks. And the first trimester screening was done for her. First trimester screening, this is the result. Okay.
This baby is living on Wi-Fi.
Pardon?
This baby is living on Wi-Fi.
Why living on Wi-Fi?
0.1 mom, Papa.
Yes, Pape is 0.1 mom. HCG 1.5, and screen positive for trisomy 13 and 18. Structurally normal baby. Okay. So what would you do now?
Invasive procedure.
Invasive procedure. And trisomy 21, 1 in 600. You want invasive procedure? Structurally normal baby. So now the question is, why is the papae small? Why is the papae low? Is it because of Down syndrome? In this case,
Placenta.
already obviously placenta. The already baby is having
Uterine PI.
placental uterine PI is high. So CVS was done as you asked for that. She was done and everything is normal. Okay. Then at 16 weeks she comes back for a review, and this is the picture.
So placenta appear heterogeneous,
Okay.
and it appears small and hyperinflated like.
Yes. If you want any information about that Doppler, tell me, I'll tell you.
Mean PI is higher side.
So if you look at your umbilical artery Doppler charts, it all starts after 18 weeks. She's only 16 weeks. So is there a point in doing umbilical artery Doppler at all in this case? I don't know. Okay. But obviously this baby is not looking good because biometric parameters are only 13 to 14 weeks. So we have to classify this baby as very early growth restriction. Very, very early growth restriction. And we said when very early growth restriction in the talk, we should think of other causes also. But this is also showing other problems of abnormal Doppler, abnormally looking placenta. So it's most likely placental related. So what do we do now? When do you want to call her back?
Obviously, we will call back at anomaly scan to see the anatomy also.
So 16 weeks to 20 weeks. Okay, you're going to call her at 20 weeks. Correct? 4 weeks from now. Do you think this baby will survive till then?
Big question mark.
Big question mark. Okay. So she comes for counseling, low papae, abnormal abdominal, role for invasive testing, no. So she comes at 20 weeks and it's an intrauterine demise. Okay. But the story does not end there. What are we supposed to do for her? Because she is now, her only question is, this is the third time I'm losing the pregnancy. What will happen next time?
So we will send this baby along with placenta for autopsy.
Okay. How will it help? Already IUD happened.
We can find some
What are we looking for in the in the autopsy?
placental villi architecture.
Okay. So placenta HPE showed large infarcts and hemorrhages. So I told the pathologist, you're not giving me anything more than what I already know. So what am I going to do? Okay. So the key take-home messages is severe placental dysfunction can present early, very, very early, and look for markers. We do the, obviously the biochemistry is also abnormal. The thing is, I was so sure it was placental dysfunction. I correlated the low papae with the abnormal placenta with the Doppler. Was there a need for an invasive procedure? Because already at 16 weeks, the baby is only 13, 14 weeks. I'm going to put a needle and aspirate whatever little amniotic fluid is there, I'm going to pull it out. Is that going to be of value? It's a matter of debate. If you go to the Western world, they'll say, okay, you have to do it. Then why did you not do exome sequencing, this, that, and all that? We look at very simple things. This is classical placental dysfunction, and we start there. But what's our future? What would you do? What any other investigations would you do next time?
Phospholipid and lupus and all those.
APL was negative, no? APL was negative. So we'll all agree that we get stuck sometimes like this. We do full thrombophilia screen. everything under the sun till no investigations are left. Then we tell the patient, please pray to God. Next time we'll put you on very early aspirin. And then in spite of APL being negative, a lot of people put her on heparin also. Okay. Sir, this baby itself karyotype is normal. So there's no role for parental karyotype here. So this is this highlighting to you that sometimes we come to feel like the end of the road, but we are not able to give reassurance to the patient, which is very difficult. Okay. So here's another patient who's 21 weeks, AC 4th centile, estimated 5th centile, umbilical artery was normal. She's 21 weeks. Okay. So in the second trimester interview, we already know how to do that. Now this shows, you can see one uterine artery, very high resistance, mean PA is 1.7. So second trimester 1.7, is it happy? Are you happy with it? Not happy with it?
It is high. More than 1.6 is high.
One more 1.5. So now they have not done anything in the first trimester. So screen negative. Again, PAPA was 0.1 here. Okay. But uterine artery Doppler was not done. Now the question is, can you start her on aspirin? No. But you have to be seen to be doing something, no? How can you tell the patient, Doppler is abnormal, but go home, I'm not going to treat you? She will go to another doctor, no? She will keep on going to doctor until one doctor gives her the aspirin, and then she'll stop the treatment there. Right? Okay, anyway. So, there is no benefit of option after 16 weeks. Now, let's see what happened to this patient. When will you call her for a repeat scan? Now, we have established the problem here. Okay. When will you call her for it? When do you want her for a repeat scan? She's 21 weeks now. 28 weeks. Any rationale for calling her at 28 weeks? Why 28 weeks? Why not 24? Or why not 26? When will you call? When do you want a repeat scan for this patient? She wants 28. You want 28 or 26? 24. You must give me a rationale for doing that. Why? AC was 5th centile. Mayank, when will you call her for repeat scan?
I will call -2 weeks of my NICU viability age.
So he's bringing a completely new picture in the person, because he's seeing the two neonatals are keeping quiet. We have to do something to them. So he says very cleverly, 2 weeks prior to NICU viability. So now please tell us, what is your NICU viability?
Well, it varies obviously with and keeping lot of parameters in mind. Recently, the survival of extreme preterms, I'm talking about babies less than 28 weeks, has improved a lot, not only in metro cities but also like in smaller centers. If we talk about Gujarat, then the very place that we are sitting at, I'm sure that the survival of babies born between 27-28 weeks has improved like anything. So for us, maybe like we can give some hope to the patient, even if the baby is doing well at about 24-25 weeks. But then doing well means that the other parameters are also have to be taken into account.
Okay. So growth restricted baby at 25 weeks by age. That means the baby will be only 22 weeks by size.
True.
So you want the size of the baby, or you are okay with the gestational age?
So I'll make it little bit simple for everyone to understand that for any neonatologist, of course, like all of us would want a full-term AGA baby.
Yes.
But then if it is a situation about, otherwise, then preterm growth retarded, preterm appropriate for age, and full-term growth retarded. So my preference would be, or maybe for that sake, that where a level 3 NICU care is available, like any pediatrician or neonatologist would want a preterm appropriate for age baby, because we know that the number of cells are less, but they have optimum function
Yes.
evolve till that age.
Yes.
The second preference would be full term small for dead baby, or maybe like a growth retarded baby, because even though like the baby would have become more mature by then, so we expect that the number of cells would be more, even though they are like not optimum functionally available to us, but still they would be expected to be better than having a preterm SGA
Yeah.
or IUGR. Whereas in case of preterm growth retarded child, we have less number of cells available, as well as they are not developed enough for functioning properly. So even preference wide a 24-25 weeker being appropriate for date is on any given day more preferable than having a 26 weeker
Yes.
only having a growth of 22
Sure.
weeks.
Sir.
Why we will
She
deliver
is-
appropriate for gestational age at 25 weeks?
No. So, no. I'm asking, sir. She is giving you this baby now. Okay. She has to deliver. Baby has to be delivered now. Are you willing to receive the baby? Let's say 24 weeks. She's going to call for repeat scan. Most likely, this Doppler is going to become abnormal, and she would need to deliver at 25 weeks. Are you going for a holiday at that time, or will you say, okay, I'll wait for the baby to come?
If we talk about the Indian scenario, 25 weeks or less than 600 grams is can be taken as the limit of viability.
Limit of viability. So the thing, we need to discuss it with the parents, okay, if they really want to give a chance or whatever it is. But we will all agree that this is not a good situation for us. If it can be avoided, as a neonatologist will say, try to get a few more weeks. So she comes at 28 weeks now. Okay, she's reached 28 weeks, and that's the growth graph. Sir, Mohit sir, can you tell about this graph?
Sir, there is a lag in the growth after 21 weeks.
Yes.
All parameters are lagging, especially abdominal circumference. So we'll definitely have a look of Doppler.
So can we now declare this as early onset growth restriction?
Yes, sir. Definitely.
We call it as early onset growth restriction. So grade 3 to 4 week lag, estimated fetal weight is 750 to 800 grams. Doppler 1.7, uterine artery, mean PA 1.3, MCA Doppler, DV Doppler is normal. Now, 800 grams, you're already smiling now. Yes, you started smiling already. You're on a safer wicket now. But let's come to the obstetrician here and say, are you going to deliver this baby now? No.
No.
Why? He's willing to take care.
But Doppler parameters are normal and gestational age is less, so it is better to wait.
Okay, so Mike, do you want to stage this Doppler now?
This is a Doppler is definitely abnormal, but it falls in a stage 1.
So what this is stage 1. What stage 1 actually means? Umbilical artery forward flow, and if it remains in stage 1, we can go up to 37 weeks.
Yes.
Correct? And it's so the thing is whether it's going to remain or no, I don't know. So I just stage 1. So review in a week's time. Now from 28 weeks to 37 weeks, are you going to screen this baby every week? Anyhow, you're going to deliver at 37 weeks. Then why do you want to call her after a week? Say they come back after 3-4 weeks, isn't it? So why is stage 1 required to be seen so
We
quickly?
don't know either it is a mild, progressive or severe.
So that's the issue. We don't know the profile of this baby,
And
how it is going to behave.
meanwhile, may I request our obstetric colleagues to please give a course of steroids to this baby?
Exactly. We are coming to that, sir.
Because you never know how this is going to evolve.
No, exactly. We are coming to that. Because that's a very important thing. So she's come to 30 weeks and 2 days. Okay. So you wanted the sera to be given at 28 weeks itself?
Well, yes, at the earliest possible opportunity, especially when we have an early
Because
FGR.
stage 1 FGR, we are actually not contemplating to deliver now.
Yeah.
Dopplers are normal.
Yeah.
It means the next 1 week, I am not going to deliver.
True.
You still want to give steroids?
Yes, I would, if it is a 28 weeks already.
Okay.
The reason being that, as rightly pointed by Dr. Mayank Bhai, that you do not know that whether this is going to be a progressive growth retarded case. And
So the baby has shown it out now. 30 weeks, Mank, stage now. Absent diastolic flow. So it has come to stage 2.
Yeah.
So stage 2, we want to deliver?
Stage 2, I will see the Doppler and I will be in a close follow-up.
Yeah, this is the Doppler.
If
can say MCA.
sorry, ductus Doppler.
Ductus, normal.
Oh, okay. So I will wait, but in a close follow-up, and if possible, if I have facility of CTG, I will do.
But at 28 weeks, he wanted steroid to be given. Would you have given the steroid at 28 weeks? Because you're still not, even at 30 weeks, you still don't want to deliver this baby. You still don't want to deliver, isn't it?
That is a
because our threshold,
debatable thing.
Early onset growth restriction, our threshold for delivery is ductus venosus. Did we not say that? So we should practice what theory was said, you know. So I'm not going to deliver now. So why do I need to steroid now? We want to be doubly cautious. What suddenly tomorrow you call and said, hey, suddenly baby is not moving. I want to deliver today. That's why he is putting himself on guard. Okay. And so let me ask you, sir. Supposing steroid was not given and the baby had to be delivered without time for steroid, do you think that baby will die because steroid was not given?
No, see, steroids, antenatal steroids, it's not that it's a all or none, like response. We can expect that the respiratory morbidity especially can be reduced by a sizable amount of about 80% in and mothers who have received antenatal steroids. And world over, it is the only antenatal intervention which has been demonstrated to have a positive impact not only on respiratory morbidities but also on some major adverse events in neonates, like including IVH and a long-term growth of the child and NEC.
How much time does the steroid work? 2 days to 7 days.
Well, I would differ on that because there are differing guidelines everywhere in the world. Even the European Society suggests that if the steroids have been given at or beyond 24 weeks of gestation, depending on the protocol over there, then they do not repeat the course. I mean, if the delivery doesn't happen within 4 weeks time. Okay. So that 2 to 7 days is not actually the duration that we expect the steroids to work only for.
Okay. So they can have an extended period of time. Yeah. So because my worry is 28 weeks we have given the steroid, 30 weeks still they are not delivering the baby. Supposing this baby will be delivered at 32 weeks, will you give a steroid again?
Well, not required, because by that time the baby would have already reached 32 weeks, which is a kind of period that we would expect the possibilities of respiratory morbidities much lesser than what we would have expected at 28 weeks.
Okay, right. So stage 2. Now, so we got the neonatals in the picture already here, and then he has told us. So what about Maxelf? When you say steroid, it always goes with Maxelf, no?
Well, the role of Maxelf as well as the protocol is that if the delivery is imminent within 24 hours,
yes,
okay, and the maturity is less than, now earlier they used to say 28 weeks, but now the recommendations that even at less than 32 weeks, if the delivery is imminent, then Maxelf has to be given.
So can these two things be given at 2 separate times? 28 weeks I have given the steroid, 31 weeks I am going to deliver. Can I just give Maxelf and deliver?
Well, people have been talking about the rescue doses of steroids, but yeah, evidence does not suggest any positive effect of it.
So we can give Maxelf alone?
Yeah, we can.
Because steroid has already been
given.
given.
We can.
Okay. So 28 to 30 week daily increment in survival is approximately 0.7%. After 30 weeks, neonatal survival rates exceed over 90%. So significant decrease in major neonatal complications after that same, as he has rightly said. So patient on routine follow-up. So key things to assess on follow-up of FGR. In these when the babies are coming, what are you actually looking for apart from the Doppler? Is it just the Doppler alone you're happy about? So, are you interested now in estimated fetal weight, looking at the abdominal circumference, whether it's growing or not growing? Is that important? We have established.
See, we have reached up to
IUGR
the
already.
Doppler, so biometry will be there.
And his
I
threshold
am-
of
I
800
am-
grams has come already.
I am also interested in mother also. I will examine mother and see what is the general condition of mother.
Okay. So the mother has got a variable blood pressure, 120 by 80, 140, 90 occasionally. Urine protein is nil. So how frequently you want to assess? Will you admit her in this hospital?
Admission is not required, but very close follow-up I will suggest, and do Doppler, including doctor's Doppler in each visit.
Even if she's staying 5 hours away from you?
Staying?
5 hours away from you.
Then we have to admit.
So when do you want her to come back? So because the blood pressure is very 140, 90, suddenly one day it is 140, 90, 2 days later it comes down to 120. You're not giving her any medication, but still watching. So you want to have a close watch at her. So 32 weeks and 3 days now. Okay. Now this is what has happened. Now tell me. This umbilical artery Doppler, occasional reversal is coming now. Occasionally. Suddenly after 4 or 5 beats, one reversal. And then it comes back to absent flow.
So at this point of time, the risk of stillbirth is higher as compared to risk of prematurity. So risk benefit ratio, I will more inclined towards the delivering baby.
Okay.
Because 32 weeks.
So can the neonatals go for the evening show while you will be delivering? Because 32 weeks, he's already said 32 weeks, I'm very, very happy. I don't even want steroids after that. So he has said that. So now my question is there a threshold for delivery now? What is the trigger for delivery at this point?
32 weeks.
Yeah. So you want to deliver now? DV is still normal. Early onset growth restriction. Remember the rule.
It is 32 weeks, that's why.
So now you are changing the rules. Because the whole goal was to push the boundary. As long as ductus venosus is normal, we want the baby to gain just. See, between 32 and 35, will you not happy with 35 more? Better than 32?
But sir, I would also like to know that what is happening with the growth.
So does it really matter? Do you really want to know? Because
yes,
see, it is instead of this baby is growing very slowly, very, very slowly. Still chugging along, it's growing along the third centile, let us say. But it's not gaining enormous weight and all that. But it's gaining gestational age. So are you interested in gestational age or the weight?
So I very clearly mentioned at the beginning of the session itself that I will always prefer premature but appropriately grown baby. So if this baby has been growing at persistently at a lesser centile, the in utero adaptation is possibly going as per the expectation. But then there are enough number of studies available world over that babies born with persistent absent diastolic flow or reversal of flow, even though they do not have reached up to a stage of reversal in the ductus venosus, their long-term outcomes have not been at par with pure preterm babies. Especially the postnatal morbidities like necrotizing enterocolitis has been a great a problem for them. It's really very, very difficult for us to feed them.
Yes.
At times they end up having significant acidosis and hypoxia, and then we feel that if we are talking about intact survival, then maybe this is not the ideal situation that we would want to be in.
Exactly. So he's now brought the word which I wanted, intact survival. Okay. So this baby in utero was very happy. The intestines were happy with the amniotic fluid. After it came out, the intestine did not get amniotic fluid, but also had to be fed, but they are not going to feed it. They're going to give IV till it quietens down. So there's always the risk of enterocolitis. So he said, okay, let's push for a little bit gestational age. So now if CTG is abnormal, biophysical profile is abnormal, any of these triggers are going to make me deliver this baby. All I'm saying is, at the slightest push of other things going wrong, we will deliver. But if all other things are, baby supposing moving well, like her is still all right, and except the umbilical artery Doppler, rest everything is all right, I would still try to gain some more time, isn't it? So NST monitoring and all that. So repeat dose is already answered that one. So LSD was done for this baby, 1.15 kg baby, was in NICU for 2 weeks, now on 6-month-old follow-up with the pediatrician. Now I want to know, when are you going to declare that this baby has got intact survival? Which is your declaration? I want the baby to tell the mother, your baby is now fine, it will come first in class, pass the NEET exam with high marks. When are you going to tell that?
Somewhere around 2 years of corrected age.
So up to 2 years. So do these parents need to be told that they have to follow for 2 years? What should be done?
Yes.
On that? So are these instructions routinely given? Because when it goes from the neonatologist to the pediatrician, there's a disconnect, isn't it?
No, whenever such a NICU graduate comes out from the NICU, they have to be put under a high risk follow-up plan.
Yes.
Which does not necessarily only include a follow-up in, like the routine OPD or just the growth monitoring. It also includes special assessments, including ROP screen, their hearing assessment, and their developmental assessment, at least by DASI, at the corrected age of 4, 8, and 12 months. And then, by and large, if up to the age of 1 year, the milestones have been appropriate,
yes,
maybe we can say at that time that yes, this baby is fine, but technically up to the age of 2 years, the child has to be followed.
So the message is very simple. All babies with growth restricted who come out, even if they do well in the NICU and come out, need a neurodevelopmental assessment at 2 years of age. It's at that time you are going to do. Now, why are we doing that? Is because in case you find out any developmental delay at that time, early intervention will help improvement. Otherwise, we miss the bus. Then it becomes too late to do that. And that's why we need to do that. So, the lessons from this particular case is we were all the time stuck on ductus venosus A-wave reversal for delivery of early onset IGR. Now, this baby was delivered much before that. Okay, much before that. And so what we are trying to say is here, you have achieved a gestational age of more than 32 weeks. So your threshold for delivery can be, the Doppler can be reduced because you have achieved more than 32 weeks. That's why the Doppler interpretation comes there. Now, what would have happened if I had done further? This lady had abnormal biophysical profile. Supposing this baby did not have an abnormal biophysical profile, there was no spontaneous decelerations on CTG, we would still have continued. Maybe I would have bought 1 week more. Because I still have not seen progression from absent diastolic flow to reverse diastolic flow. I have not seen that progression as yet. So I would still have bought some more time. But here, because the other parameters were abnormal, so the message is, it's not Doppler alone that's going to make you decide. Maternal condition and other parameters like biophysical profile, like movement of the baby, all these things also count. Take a holistic view of the whole baby, and but we can certainly say, since I have crossed the NICU threshold and it's okay to deliver in case other things go wrong. In case other things are all right, I would still try to get maximum possible. Always try to get maximum gestational age, but I will not be pushed to take so much risk to ignore saying, mother says I'm not able to feel fetal movements. I will give importance to her. So that is where this message is there. So I think we will stop here. We are already very late.
Sir, I would like to put one question forward to the audience pertaining to this particular situation only, that maybe at 28 weeks it was just absent end diastolic flow. for whatever reason, like decreased fetal movement or for maybe PIH developing, if this mother was reviewed at 30 weeks, for example, of course her plan was to review after 4 weeks, and at that point of time, if there would have been the same findings, that occasional reversal but normal like DV flows, okay, then wouldn't we consider giving a chance to the baby, okay, considering that we already know that the survival rates of 30-weeker are now more than 90%, I would say, or around 90% in India. Then would we really still wait for a finding of abnormal DV Doppler to happen, say at 31 or 32 weeks, or we should just decide based on the risk and advantage ratio?
There are no right or wrong answers for this. That's why we say that particular obstetric team sits with the neonatologist, look at your own NICU protocols, and then decide whether you want it out or you want some more time. It's ultimately the decision is between you two. Okay. If you go by the rule book, this baby did not deserve to deliver at 30 weeks. Deserved to deliver at 32 because of other things that happened. Yeah. Okay. Thank you.
Thank you, sir. Thank you. Well, while we are at Kutch, I would, because it just came up to my mind that our, maybe I can say India's tiniest pair of surviving twins who were delivered at 23 weeks gestation and, managed at our center belong to this very region from Kutch. The mother used to be, the mother is both, in fact, parents are dentist. And why I just realized this thing was that because though they were born at 23 weeks, they were appropriate for date. The parents decided to take chance, and then with the God's grace, they are big followers of Murari Bapu. Birth weight, baby boy was around 600 and baby girl maybe just 550 mark or so. Yeah. Yes. So in utero transfer, of course, that's the most important thing. I mean, when we are talking about patient being in periphery, and if you come across any such thing, then the best thing would be in utero transfer to a center where optimum care can be offered. That was the idea of bringing this point, that in utero transfer is something that we should always keep in our mind. Thank you.
So thank you all the panelists for giving us this knowledge extravaganza. We'll have a group photograph with the panelists. Chairpersons and panelists, please come up for the photograph.